face challenges in terms of, sometimes what the role the clot plays, the nature of clot plays, or what are the nature of the artery, including intracranial atherosclerosis plays in recanalization. What kind of drugs can we use? How can we modify our techniques? So I think we have got a perfect panel for this discussion. And I think, Raj, we can just get going.
Yes. So I'm just going to introduce Dr. Fischer. When this thought came to me, I did speak to Dr. Fischer, why don't we do such a thing? And he readily agreed for that. And I think this is how the whole concept came about. And he had helped me put together the panelist as well. So Dr. Fischer is a professor for acute neurology and stroke at the Department of Neurology, University Hospital, Bern. He is the co-chair for the Stroke Center, Bern. And he was a former Secretary General of the European Stroke Organization. And he is pretty much involved in quite a lot of research. He is the co-principal investigator for SWITCH study, and he is the PI for the ELAN trial, and co-PI for the SWIFT Direct. I'd like to really thank Dr. Fischer for taking time out. And over to you, Dr. Vipul, to introduce Dr. Raul and Dr. Mikael.
Sure. Thanks, Raj. And it's a pleasure to have Dr. Raul Nogueira with us. I've met him previously, I've heard his talks, and I thoroughly enjoyed it. I've tried a lot to get him to our country to take these lectures, but today we'll have an online one. So he was trained in MGH and Birmingham and Women's Hospital, Harvard Medical School. And he did his fellowship from vascular and critical care neurology and diagnostic neurology, again from the same institution. And later on, of course, he started this center, the Marcus Stroke and Neurosciences Center at Grade Memorial Hospital, Emory University. And he's one of the foremost authorities in stroke intervention. He has been the former past SCNVI president, as well as taken role in principal investigation, many trials, including Trevor 2, Penumbra 3D separator, Dawn trial, BEST trial, as well as in the steering committee of SWIFT trial, SWIFT Prime trial, Trevor registry, many of them. So great to have you all here. And Dr. Mikael, one second, I'll just. And Dr. Mikael Mazighi, I hope you pardon me if the pronunciation is not perfect.
Sure. That's perfect.
Again, it's great to have you here. I haven't met you, but I've gone through these details. They're absolutely wonderful. And he's in Department of Neurology and Larry Hospital in Paris, as well as in Foundation Rothschild Hospital. Both of them are very renowned, stroke and neurointervention hospitals. I personally visited Foundation Rothschild Hospital many times when Professor Jack Murray was there. And he has done his research fellowship vascular biology and followed by fellowship interventional neuroradiology from Larry Hospital in Paris, and then a research fellowship in interventional neurology from Cleveland Clinic. Again, he has taken part in many studies and many trials, and he's on the editorial board of many journals, including Stroke and Neurointervention. And it's a pleasure to have you here, Mikael. I'm sorry I'm not able to go through the full introduction for the sake of time. I hope you forgive us for the same. And I think, Raj, now, if everybody's okay with it, we can start with the clinical discussion. Yeah.
So we want it to be an interactive session, and therefore there will be a lot of questions through the presentation. So the first thing I would like to start off with is thrombolytic therapy. There are quite a few neurologists in the audience as well. So the question is to Dr. Fischer. So what is your approach regarding thrombolytic therapy in large vessel occlusion? How effective do you think? Is there a risk for fragmentation of these clots if you give thrombolytic therapy? And what is your strategy for bridging thrombolysis? Are there any group of patients where you would say, no, I would not thrombolize? So if you can go through that, Dr. Fischer.
Yeah, thank you very much. This is a very hot topic. And first of all, and I think that's very important to state at the very beginning, bridging thrombolysis is the standard therapy in all patients with large vessel occlusion so far. So if a patient is coming in the time window of 4.5 hours and he has a large vessel occlusion, intravenous thrombolysis is standard of care. So you probably want to ask me now, should we give TPA, alteplase, or tenecteplase? And you know that this is also a very interesting question. And you know that Bruce Campbell from Australia did a trial where they compared tenecteplase with RTPA. And this study has nicely shown that if you give tenecteplase, the early recanalization rates in these patients is higher compared to patients if you give TPA. And it also makes sense because you give the full dose of the drug immediately, and whereas with TPA you give it over 1 hour. Nevertheless, TPA is still the standard of care in most sites, and we still don't know whether tenecteplase is equally effective in all other types of stroke. And often, when you start tenecteplase or TPA, alteplase, you do not know whether the patient has already a large vessel occlusion or not. So currently, in most countries, the state of the art is to give TPA, and in selected countries, they give already tenecteplase. What about the effectiveness? Well, we know that the bigger the clot, the bigger the size of the clot, and I think we will have an interesting discussion also with Mikael, who has done a lot of research about the clot composition and response to TPA. We know that the bigger the clot, the less likely the recanalization rate in these patients. And therefore the question is coming up, is it really necessary to give TPA in all these patients? Because we know that some patients might have a risk of hemorrhage. And what are the patients having a high risk? We know these are the patients with the very high NIH, the patients who already have a huge infarction, have a very low aspect scores, very old patients, patients with microbleeds, patients with diabetes. So in these patients, additional application of TPA is probably not always, we don't know whether this really is an additional benefit. And therefore you probably know that there are several ongoing trials comparing direct mechanical thrombectomy versus bridging thrombolysis. One of these trials has already been published. It's this Japanese trial or presented. It's a Japanese trial called SKIP trial. And they compared bridging thrombolysis with direct MT in 200 Japanese patients. And what is important to know, in Japan, only the reduced dose of TPA is licensed. So they gave 2/3 of the regular TPA dose. And if you look at the results of this study, the study was underpowered to give a conclusion. Nevertheless, there was no difference in between the two groups, and the risk of having a hemorrhage was higher in the TPA group. So we are very keen to know the results of the direct MT trial, which will be presented at the ESOC web conference in May. So within 2 weeks, we will know the results of the direct MT trial, and the other trials with direct, Mr. Clean, no IV, and an Australian trial are ongoing. But until we know the results of these trials, we always should give TPA as first-line therapy.
Okay, so within a few weeks, we may get to know,
Yes.
we may be wiser than what we are right now.
Yes.
Okay, so moving on from thrombolysis, so the main topic for today was to discuss the clots, the arteries, and the techniques as well. So I want to present two cases to put forward two different presentations. This is a 60-year-old male who presented with left-sided symptoms and neglect 3.5 hours from onset. If you see, there's a dense clot in the right MCA. The clot length is around 1 centimeter, just over 1 centimeter. You see there is some blooming. And for this patient, what we did was we did a solitaire thrombectomy. So you notice there is a balloon guide. We have taken the solitaire across, and we were able to achieve good first pass, complete reperfusion, a TK3 reperfusion. So this was what we thought was a red clot. We went with solitaire and we were able to achieve good reperfusion. And the next companion case would be a 35-year-old male who presented with left-sided weakness, dysarthria. So he presented to a peripheral center where he was thrombolyzed at 1 hour of onset, but then reaches our center at 4.5 hours. So he has a large deficit. The artery hadn't opened up. If you see, there may be some hyperdense area, the distal M1, but there's not really much of blooming and a very long clot, almost 2.5 centimeters. And in this patient, what we did was we went full on. We did a badass technique where we have a balloon guide, take an aspiration catheter, use a Solumbra, as well as the balloon. But however, after the first pass, what we noticed was there's a clot in the inferior division, there's a clot in the ACA. So there was embolism in the distal in the territory as well as new territories. So then we had to do solitary thrombectomy for the distal clots, and we were able to achieve TK3. So these are the two questions here. I mean, one was a red clot, the other may have been a fibrin-rich clot. So there are a lot of questions that arises from here. So I would like to stop share here.
Yeah, so maybe Mikael, you can tell us about it. I mean, how type of clot do you try to differentiate? What are the compositions? Do you try to differentiate the
Rajsrinivas Parthasarathy has stopped screen share.
Okay, should I share it again for?
No, just read out the question, Raj.
Okay, so what do you think, Mikael? What are the types of clots, and is imaging can it reliably differentiate the type of clots?
Well, as you know, there is a lot of controversy regarding imaging, clot imaging. And one of the explanations is that there is a wide heterogeneity of, in terms of components of the intracranial clots. And they all have platelets, red blood cells, white blood cells, and these cellular components may change in proportion. There is a lot of literature trying to make a relationship between the clot composition and the etiology, making also relationship between the cellular components and the resistance to reperfusion. I think we still need strong data, and there are no very, evidence showing that a clot is more prone to a type of reperfusion strategy. It seems that the more the clot is richer in red blood cells, then this type of clot seems to be more prone to reperfuse easily. In the opposite situation, when you have a higher proportion of platelets, these type of clots seem to be more resistant to lytic therapies. But again, the data underlying this evidence are still need to be, we need more data, and we need more strong data to be more comfortable with these evidences. So for the moment, I don't think that imaging will bring sufficient evidence to make any decision regarding reperfusion strategy. I think the most important information is the clot length, and the clot length is really critical to define any lytic resistance. And the clot composition identified by brain imaging still needs more evidence to base any strategy on.
And Dr. Fischer, can you throw light on if thrombolysis based on clot composition, is there any difference?
Well, I think the person who should answer this question is Mikael, because he has done an excellent paper. We just talked about it.
Okay.
It has been published in Neurology last year, and okay. What they are describing really makes sense. They were looking at the clot composition, and what they could see is that you have a fibrin sheet around the clot, and in the inside you have the composition, the red cells, and this kind of sheet protects a little bit the clot from getting treated or thrombolized with TPA. And I think that really makes sense that as soon as you can disrupt the sheet, then eventually the recalization and the reperfusion is better. But I think I have to pass the question over to Mikael, because he is the expert in regarding this question. But I think it's a very interesting topic, and I'm very much convinced that in the future, if we have better imaging modalities, if we can say, well, this is a red clot, this is a fibrin-rich clot, or the composition is like this or that, this will target our therapy. So eventually we will say, well, if you have a patient with a long clot, which is fibrin-rich, eventually TPA does not work, so we will go for direct MT. If you have a small clot which is red, so then TPA should definitely be treated. But I would be very keen to know the answer also from Mikael.
Yes, thank you, Urs. As you said, it was very interesting to see that although there is a wide heterogeneity in terms of cellular components in the brain clots, they have a common structure. They have a dense shell and they have a loose core, and this dense shell seems to give resistance to lytic therapy. And when we analyze the shell, it looks like in this shell there are a high proportion of nets. You know, these are these fragments of DNA that are released by the neutrophils. And when you give DNAs, you know, enzymes to cut these nets, then you improve the efficacy of lytic therapies. So the association of lytic therapies with new agents like DNAs may be new options to improve reperfusion efficacy of pharmacological approaches.
May I kindly ask you a question? Have you also experienced whether we always are scared that you have a disruption of the clot, the fragmentation of the clot. Do you have some experience about whether the clot composition matters regarding disruption or distal emboli?
Well, for the moment, no. We are much more working on clot resistance and clot composition, but okay, not enough looking at clot fragmentation and clot composition. And this is really, in fact, you're right, a very important avenue to look at.
Thank you very much, Dr. Mikael and Dr. Fischer. So the next question is then, as we had touched upon,
Rajsrinivas Parthasarathy has started screen share.
Dr. Vipul, do you want to?
1 second, something.
Okay, so
yeah.
So the question is to Dr. Raul Nogueira. How do you say, now we have discussed about thrombolytic therapy. What would you say, do you choose your technique based on the type of clot? Does one technique is better than the other to prevent fragmentation and embolism to new territory or distal territory?
So Raul, we have heard a lot about, I heard your talks talking about how that kind of clot makes a difference in thrombectomy. So we thought, and please, you can do slide share.
Parthasarathy has stopped screen share.
And Dr. Raul, you can share your slides so that we can understand the concepts.
Sure. So we agree with what has been said in terms of this is still evidence that you are building, but what I would like to do here is perhaps talk a little bit about what you have learned based on experience and good analysis of our clots and of the literature. So it's the idea that hopefully where you're gonna go is again, it's the principle of precision medicine. You're gonna try to individualize patient selection, types of clots, techniques, and so on and so forth, right? It's about individualizing what we do. So in terms of this whole idea about number of passes, one of the principles that it's very important, and I'll try to clarify for the group, is that you need to understand the difference between predictors of outcome and treatment effect modifiers. So people try to say that if you do too many passes, you're gonna have a futile thrombectomy. That's not necessarily the case. We know that low number of passes is a good thing, right? You have the first pass effect, higher rates of good outcomes, lower rates of mortality. You know that a higher number of passes is a bad thing. The more passes you give, the lower is your subsequent chance of open the blood vessel, the lower is your chance of having a good outcome. So there is no question that there is a correlation between number of passes and outcomes. But it doesn't mean that you should give up because you are reaching way too many passes. There are other concerns other than just the favorable outcomes. You may actually hurt patients by doing too many passes. It is a paper from the Aster trial where they showed almost a 10-fold increase in the chances of parenchymal hematoma if you give more than 3 passes with a stent retriever. Okay. One of the things that it's interesting to understand about clots is that every pass you give, you are actually changing the structure of the clot. And that may have a dependence on the composition of the clot. So here you have 2 types of clots, red blood cell rich clot, which it's easy to retrieve, but then a fibrin rich clot, which is a lot harder to retrieve. Okay, these clots, we're gonna talk about them. They tend to roll, they are very hard. But if you observe this clot before the pass and after the pass, you can see that the clot has actually changing shape. The clot now is more compressed, as you can see here.
So
we can't,
Dr.
Dr.
Raul,
Raul, you have to screen share. If you go at the bottom, there's a share screen option.
Oh, so you are not seeing the slides?
No, we couldn't see there.
Oh, I'm sorry. I wish you had told me about that earlier.
No, it's all right. Go to the on the Zoom. There's an option of share screen.
Box. Yeah, arrow in a green box, a share screen. Yeah.
Okay.
Is your presentation in the same computer?
Yes, it is.
Okay, then you should be able to go for a share screen at the bottom. So so you have the participants, Q&A, chat box, and the share screen next. So if you click on the share screen, there is an option of sharing your PowerPoint.
I think perhaps
should I send a photograph on the on your WhatsApp so that
systems to grant access.
Raj, I'm setting one with the arrow.
okay, the meanwhile
I think perhaps we could have the discussion of someone else, and then we figure this out and you come back to it later.
okay.
Because it's...
Raul G. Nogueira has started screen share.
Okay, we can...
Now it's coming.
Yeah, now it's coming, yeah.
Wow.
All right, so can you see it now?
Yes.
Yes, we can
All right,
see it.
so let me just go over this really quick again. So again, the idea here is to incorporate individualization of decision making in our process. So it's this idea of precision medicine. Of the disclosures, we talk a little bit about the first pass reperfusion. That's always the goal. Obviously, more passes, lower chances of reperfusion, worse outcomes. We talk about the fact that this paper from Aster showed, as you can see here, an odds ratio of over 9, so almost a 10-fold increase in the chances of a parenchymal hematoma after 3 passes. And then one of the things that it's important for us to understand is this. So here we have two types of clots. One is an erythrocytic rich clot, so RBC rich clot, red clot. The other one is a white clot, a fibrin rich clot, okay? And these clots, they behave very differently in relation to the different techniques. As you can see here, the erythrocytic clot comes out very easily, as opposed to the fibrin-rich clot, which doesn't move as much, right? It has a lot of friction, and it tends to roll through the stent retriever. But if you observe this clot, specifically the fibrin-rich white clot, before and after, you can see that the clot actually gets more compressed every time that you manipulate the clot with an additional pass, okay? And the problem is, the more passes you give, the higher is the compression of the clot. And with increased compression, as you can see here, you have a higher coefficient of friction between the clot and the blood vessel wall. So you actually make the retrieval of the clot harder, more difficult, okay? So it's very important that you understand that the more passes we give, okay, we are changing the environment of the occlusive lesion, not only at the clot level, but also at the vessel wall by endothelial denudation, vasospasm. So it's important that you understand this problem to actually start thinking about how you can treat this. So very often use intraarterial vasodilators during our procedures. Specifically, we tend to use Murinon, sometimes nicardipine. And when you have more difficult cases with multiple passes, we tend to use tyrofibon as well, but more commonly just vasodilators. But what you learn here is that in summary, when you give more than 3 passes, you actually have a higher rate of compaction of the clot. Higher rate of compaction, we have higher friction, lower chances of reperfusion, lower chances of good outcome, and more passes also give you a higher chances of parenchymal hematoma. But then the question comes then, if you give him more passes, you have a lower chance of success and a higher chance of a problem. Should we stop them? And here is what, I think this is probably the most important message that I could give in general to all of you. There is a lot of confusion in our field about what is a predictor of outcome versus a treatment effect modifier. And because of this confusion, we are misinterpreting a lot of the data you see. So decision-making acute stroke has lagged behind decision-making interventional cardiology because the way we start this. We start acute stroke, mechanical thrombectomy specifically, with single-arm uncontrolled trials, right? A lot of our knowledge about intraarterial therapy came from having just thrombectomy single-arm trials, endovascular therapy, intraarterial technologies, where you were comparing 2 patients that you were treated. When you compare a patient that is treated with a patient that is also treated, the only thing you can establish are the predictors of outcome. Then you say, yes, age, stroke severity, aspects, higher number of passes, they are predictors of outcomes. Okay? If I compare different patients that are treated, these are bad things, there is no question about it. But had we done what cardiologists did, which we finally did since 2014, 2015, which is randomized control trials, we can now finally compare similar patients that underwent thrombectomy versus not, okay? And when you compare a patient that went treatment versus a similar patient that didn't have treatment, you finally can look at treatment effect modifiers. And we now know that age, stroke severity, even aspect scores, right? Even aspects 3 to 5 seem to benefit. And, you know, I'll show you that greater than 3 passes, these things do not modify the treatment, okay? So yes, your chances of having a good outcome will go down, but it doesn't mean that it's not better to keep treating the patient than stopping. So these are 2 different things, okay? when you look at predictors of outcome, it tells you who's gonna do well with the treatment. However, the treatment effect modifier tells you who's gonna do better with the treatment. And these are two different things, okay? So if you look at this paper here from the Catalonia group, you can see that they look at the number of passes, okay? And you can see that the chances of having a good outcome at 90 days, it's still higher in people who have 4 or 5 passes than in the people that they just gave up and did not recanalize. So again, more passes is a bad thing, but it doesn't mean that you should give up after 3 passes or so. Okay. The other thing you can see here is achieving a delayed TK3 may even be better than achieving an earlier TK2B or just about the same, okay? So it's quite complex. This is another paper. This one is from UPMC where they look at the same thing. They look at the patients that they could open easier, 2 to 3 passes, the ones that were refractory greater than the 4 passes, okay? But then the patients that they couldn't have a successful reperfusion. And the point here is the chances of a good outcome are obviously higher here, but it's still better to keep going and having 5, 6, 7, 8 passes than actually stopping at the 0 to 2A. As you can see here, the chances of having a good outcome are still better if you keep trying and you open the vessel than you give up. So this idea that you should stop after a few passes is not a good one. But we know that if you keep trying, if you keep treating the patient, you're gonna at some point get into trouble. So what you have to do is individualize the decision according to the clinical severity. If the patient has a high clinical severity, you should never give up because a complication is just as bad as a failure. Those patients don't do well, right? You almost never see a patient with an NIH stroke scale of 18 or 24 do well without reperfusion. However, if you have a patient with a low clinical deficit, a low NIH stroke scale, and an M1 occlusion, those are patients that sometimes the natural history is better than a complication. So you may want to be more conservative with those patients. But the idea of refractory thrombectomy is oftentimes a matter of technically suboptimal thrombectomy. A lot of the papers that I showed to you that did multiple passes, the doctors kept using the same technique over and over again. So the idea here is try to individualize your technique and progress your technique because these clots, they are different. And there are 2 reasons why you may face challenge with thrombectomy. And we're gonna talk about both today. One is the underlying occlusive lesion, and the other one is the vascular anatomy. Erythrocytic clots are probably things that help you being successful. On the other hand, fibrin-rich clots will give you a higher chance of failure. Okay? Calcific emboli are probably the worst of all clots. Intracranial atherosclerotic disease will be a predictor of failure if you don't recognize and treat properly. Okay? On the other hand, you have to deal with vascular anatomy and challenges there in terms of tortuous access. There are also issues with intracranial vessel curvature and angulation that you need to understand to help in deciding not only your technical modality, but also the technique with either modality. Occlusion branches at the level of the bifurcation, these are big challenges. I think Mikael is going to talk about the double stent river technique. So I'm going to talk a little bit about these different occlusions.
Dr. Raul, I can say something. So we are going to discuss these very questions which you mentioned about ICAD, about curvatures, about anatomy, in the later questions. So you want to cover them now or as and when the questions come up? What do you say? Is it okay if we sort of bring up these questions?
But Dr. Raul,
or do you want to say something very specific about how your strategy changes depending upon the clot? Do you change your thrombectomy technique? I mean, about the clot part. And Rest we are going to cover. Yeah.
So that's exactly what you're going to cover now is this point that there are two things here. One is, first of all, can you tell this clot apart, right? As Mikael said, there isn't a perfect way, okay? But then the question becomes, what do we know about clot composition and technique? Those are the two points I was thinking about covering now.
Yes,
and then you could break down in questions.
Yeah,
Does
that is
make
fine.
Sense?
Please carry on.
So Mikael talked about that. We can't really tell this clot apart very well, okay? But what we know is this. This is a paper from David Libeskind, and we know there is a correlation between the hyperdense vessel on CT and the blooming artifact on MRI and the amount of iron, right? These appearances are defined by the amount of iron, by the amount of red blood cells that you have. And if you look at the mean, there is definitely a correlation. When you look at the population, the mean chances of having a hyperdense MCA will be higher when you have erythrocytic clots. You can see the same thing here with blooming. But when you look at individual cases, we can see that, you know, you may have clots that are hyperdense that don't have much erythrocytes, okay? And the same thing, you may have clots that are not, that have blooming that don't have many erythrocytes. So I would say on average this helps, but it's not perfect. And part of the problem is these clots are very mixed. So it depends on a lot on the area of the clot that you are imaging. But again, it's not perfect, but I think it's a reasonable guide because on average it works. There is a technology that has been developed now where the idea is to put microsensors on the distal end of an old 14 microguide wire. And using these microsensors, you might be able to actually more accurately identify the composition of the clot. But again, why is this important? Okay. We started studying clot about over 15 years ago, and these are early times where you were doing MRSI retriever, and you have an erythrocytic clot here, a red blood cell clot, and what you can see is when you have these clots, first of all, you still have mature areas, but you have these areas under maturation. And when you have erythrocytic clots, the fibrin can't be fully integrated, so it has its pitted appearance. And it's important because it makes it softer and more breakable, more friable, okay? It's more easy to disrupt. When you have a white clot, it's rich in fibrin, you see here the fibrin makes the clot cohesive. So it's like a piece of rubber. It's very well integrated, okay? And then this causes differences in what I believe 3 main mechanical properties of the clots that have an impact on your decision of using a stent retriever or a contact aspiration. First of all, we know that red blood cells will cause greater deformability of the clot, right? That's a property of the red blood cells. Secondly, the red blood cells, as I explained, it will make the fibrin matrix more disruptive. So it's gonna increase the friability of the clot, the capability of the clot to break in smaller pieces. That's why I think, Raj, is that the second case you had where you had multiple emboli was probably an erythrocytic clot because the fibrin-rich clot, it doesn't tend to break in small pieces. And finally, the friction, right? And you're gonna talk a little bit about the friction. It's very different across these clots. So the ability of the stent retriever to penetrate the clot or not, the ability of the clot to be broken by the different mechanical devices, and how hard it is to move the clot are things that will vary according to the clot nature. How did you get to this conclusion? throughout my career, I always took pictures of the clots that I retrieve. And what I noticed is whenever I had a picture of an erythrocytic stent retriever, the clots look red. And I always started with a stent retriever. That was my first line technique. So the clots look like this. Then when I fail stent retriever, I try aspiration. And I noticed that the pictures that I had with aspiration, the clot looked like this. So in general, these were clots that had failed stent retriever, but had responded well with aspiration. So we thought that fibrin-rich clot were more amenable to aspiration and erythrocytic clot better for stent retriever. And I'll try to explain why that might be the case. When you have erythrocytic clot, why we don't start with aspiration? Even though there are 3 papers showing that these technologies are kind of similar, including a paper that we led. If you look here at the largest of these papers, the Compass, a lot of these patients, as many as about 40%, didn't use a balloon guide catheter, which is a problem. You see here another paper from Germany, again, showing that when you compare ADAPT with the stent retriever technique, okay, the results are actually better. And the number of passes is lower. And here might be the reason. So here you have a mixed clot, okay? But what you can see here is that when you use aspiration, you can grab the head of the clot, okay? You grab the head of the clot, but you do not control the tail of the clot. And if the tail of the clot is erythrocytic and easy to break, it breaks in pieces, okay? So the problem with ADAPT is you don't control the whole length of the clot. The other thing I want to call your attention is you think these catheters are very big, and they aren't. If you look at the idea of a 0.68 catheter, that's 1.7 millimeters only. The idea of a 74, it's 188. It's a lot smaller than the M1, okay? And you have to understand the cross-section area, which is actually even a bigger measure of this problem. So in general, the M1 will be about 2.5 times higher in cross-section area than one of these aspiration catheters, okay? So again, if you have a clot that it's white, you can cork it and remove with aspiration. But if you have a clot that it's red, it's gonna break into pieces. Here is to show the issue of friction, okay? The red blood cell clot has a very low friction coefficient. As you can see here, it moves very easily. The fibrin-rich clot has a high friction coefficient. It does not move easily. So these are much more refractory clots to move. So when you approach these 2 different clots with a stent retriever, the behavior will be very different. If you have a red clot, these are soft clots that deform, and then the clot gets incorporated by the stent retriever. If you have a white clot, these are hard clots, they do not deform. It's like a piece of rubber, and they push the mesh of the stent retriever out. They don't get inside the stent retriever. Moreover, these clots, red clots, they have low friction, as I showed. So you have high incorporation with low friction. The clot moves out with the stent retriever if it's red. But here, you have low incorporation with high friction. The clot rolls through the stent retriever. It does not come out. And here you can see again this mixed type of clot, and what you see is the red piece comes out easily, as opposed to the white piece that you can see it rolls through the stent retriever, right? It doesn't get incorporated, and it has a high friction, so it stays. So again, the fibrin rich is deformable with low friction. It's gonna come out with the stent retriever. Erythrocytic clot, easy. Good for the stent retriever. The fibrin rich, it's non-deformable, doesn't get in the stent retriever matrix, It's gonna roll, it does not come out. So I think what you see here is this idea that two different techniques may do better or worse according to the nature of the clot. Maybe I'll break here for us to discuss a little more and we can illustrate this a little better, but let me just show what you have in terms of data about this, okay? So when we have in Aster, which was a neutral trial, right? It said that stent retriever and contact aspiration was the same. But what the investigators from Astra did in this paper is they look at the patients that have blooming artifact, 71% of them, okay? What I told you is blooming artifact is erythrocytic, right? So when you have these types of clot with blooming artifact, which are probably erythrocytic, contact aspiration achieved a lower rate of full reperfusion, TQ2C and 3, with a risk ratio of 0.60. That was statistically significant, okay? In the clots that didn't have blooming artifact, that did not happen. But then if you look at the first line therapy in the patients with blooming artifact, the use of a stent retriever was statistically significant associated with lower disability. So again, what this says is if you have blooming, contact aspiration is worse than stent retriever in terms of full reperfusion and then good outcomes at 90 days, okay? And the reason for that is contact aspiration is gonna open that erythrocytic clot, but you're gonna have a TQ2B or a TQ2A. You're gonna have distal emboli because it's a friable clot. It's a clot that breaks. There are other papers where here it's asked in trace where they again establish that blooming is an independent predictor of good outcomes and good response to stent retriever. This is a paper that shows that hyperdense clots respond better to intravenous TPA, as you can see here, higher Hounsfield units, better response to intravenous TPA. And another paper that it shows that hyperdense MCA is an independent predictor of response to solitaire. And this is data from our center just to finalize this discussion about technique and clot composition, where you look at about over 900 patients with anterior circulation occlusion, and we specifically want to know first pass full reperfusion, TQ2C and 3, which was achieving about 1/3 of the cases, okay? About 62% of the patients had the hyperdense vessel sign, and about 38% of the patients didn't. When you look at the chances of full first pass reperfusion in outpatients, what you see here is that the balloon guide catheter correlates with that, and that's it. However, if I look at the chances in just the cohort of patients that had a hyperdense vessel, we can see that not only a balloon guide catheter, but the use of a stent retriever as opposed to contact aspiration correlates with a better response, with an odds ratio of 2.1. So again, if you have a dense vessel, just like in the other paper, if you have blooming artifact, it may be the case that stent retriever versus contact aspiration will be better. And this is another way of looking at the data where you see here, again, as a function of hyperdense vessel, stent retriever will give you a better response. However, if you don't have a hyperdense vessel, it may be the case that contact aspiration might be better. As you can see here, the response is towards the other direction. And it's almost statistically significant, but the sample size is relatively small for contact aspiration. So the idea here is that you need to adjust our technique potentially to the type of clot. But again, if you are using a stent retriever 1-2 passes, please move to a different technique, try adapt, because the clot composition may not be a good one for a stent retrieval. I think that's the main message here.
Great. That
I
was
think we can break and discuss.
that was absolutely wonderful and cleared up many concepts. Thanks a lot. I think Raj, would you like to go for the next question? And again, we are going to keep coming back to Dr. Raul, Dr. Mikael, again asking how to improve the outcomes in these patients. So I think Dr. Raul, maybe you'll have to stop the share screen. Raj, you're muted.
You'll have to stop share. You go to the top end of your screen, there will be an option of stopping share. So if you go on the top end, there is a green.
Nogueira has stopped
great.
Screen share.
Great, Raj. So,
Yeah, sorry.
Rajsrinivas Parthasarathy has started screen share.
all right. So, basically talking about from clot, now I think we are going to have other different issues which may affect our outcomes. I think this is a case, again, Rajsrinivas had done it. I think in the angiogram, what we can see that there is a clot at the ICA bifurcation extending to both MC and ACA, and there seems to be a good anterior communicating artery. And here, I think stent retrieval thrombectomy was done, but there was some distal embolism into the anterior cerebral artery. So, Mikael, we'd like to discuss these issues with you. That does the geometry of the clot, having like this kind of wire clot influence your strategy? Having a good anterior posture communicating, does it play a role? When would you like to use maybe double solitaire or modification of the usual techniques? So you can start your share screen.
Okay, I'm going to stop share. Yeah.
Rajsrinivas Parthasarathy has stopped screen share. Michael Mazighi has started screen share.
So do you see my screen?
Yes, we can see yours.
You can see it?
Yes.
Okay. So I just wanted to share with you this this case of 76 years old male. This patient is, as you can see on the vitamin K antagonist, Plavix and aspirin. Actually, he has a cardiac pump. That's why he has this very strong anti-thrombotic regimen. And he waked up at 6 a.m. and 6:15, he experienced a right hemiplegia and aphasia. When it comes to the emergency department, you can see that his NIH is 22. And due to this cardiac pump, he cannot have MR. He has a CT and a CTA at 8 a.m. So we are 1 hour and 45 minutes after stroke onset. His INR is 2.6. And that's the image that you can see. So when on the plain CT, there is an hyperdense termination of the carotid in favor of the presence of the clot. And you can see in the CTA that the M1, left M1 is occluded, and we don't see quite well the termination of the carotid. Probably there is clot in there, and there is another vision of the CT with almost all the MCA territory which is missing. So that's the angio. You can see that with the first run, we can confirm that, in fact, the M1 segment is occluded. There is a thrombus that reaches the termination of the ICA, and the anterior A2 segment seems to be occluded as well. You can see here the lateral view. We have the PCOM and the anterior choroidal artery, and clot in the terminal segment of the ICA. So the first choice in this case that could be a source of debate, but in this case, the contact aspiration was chosen. So there was a neuron max that you can see here that was a position in the subpetrous position, and within the neuron max, there was an A64 that was chosen for contact aspiration, and you can see here the result of the first pass. So M1 seems to be reperfused, but still we don't see any clear M2 segment, and we are still clot here in the termination of the carotid, and the A2 segment of the anterocerebral artery seems to do better. So given there was a second attempt with the contact aspiration with no better results, so there was a move for the third pass with a stent retriever. The stent retriever here was what's chosen was the ERIC. So with this aspiration and the ERIC, you can see here the ERIC on the X-ray, and you can see here the result. Again, we don't have a complete filling of the MCA territory, only the M1, and still there is a huge clot on the termination of the carotid, which is in the beginning of the ACA and in the M1 segments. So in this situation, to try to catch better this resistant or refractory clot, we decide to combine two stent retrievers. We choose to put a solitaire 620 on the MCA across the carotid termination here with the ERIC, which was across the A1 segment and the carotid termination. And this was combined with the aspiration. And you can see on the left side of the slide, the result with, again, probably a better feeling here of the M1 and M2 segments, but a failure again to retrieve the clot, which still stands here in the termination of the carotid. So we change again stent retriever, putting this time the solitaire in the A1 segment and another stent retriever, the hemotrap on the M1 segment. And you can see here the results, which is even worse. Although the ACA is doing better, you can see that the clot is still staying in the termination of the carotid, and we've lost the M2 segments. So after 7 passes, we decided to stop. That's the final result. You can see here that still the clot is sitting in the termination of the carotid artery, bulging in the origin of the M1. And you can see that the result is at the best a TK2B, but the feeling is not correct. So my take-home message is the double stent retriever approach maybe it shows in this type of situation when we think that we cannot catch the clot only landing the stent retriever in one artery, but still the efficacy is debatable. And I think we have to discuss also the safety. What is the safety of having the 2 stent retrievers in the brain arteries? What is the dissection risk? What is the risk of erratic emboli, which may be a result of the interaction between the devices, again on the clot structure, on the clot disruption, but also in the brain arteries. So I'll try to. Yeah.
Michael Mazighi has stopped screen share.
Raj, you're there?
Yes, I'm there. Yeah. So
it was a very nice, very challenging. In fact, it brought out a lot of issues which are discussed by Dr. Raul.
Screen share.
And very nice case. And you showed number of passes done to try to recanalize still as much as possible. Thank you.
So a follow-on question to Mikael again. So what is your choice of technique, Mikael? Like you discussed double solitaires, but what is your sort of like first option if a patient comes into your ER with a stroke? Do you go for a Solymbra or a solitaire?
So as Raul said, I think we know the critical importance of the first pass effect. And I must say that in my perspective, to optimize the first pass effect, my first option will be a Solymbra. We may discuss if we have a very short clot, which looks like a fibrin-rich clot, to choose the contact aspiration. But I must say that again, I'm looking for the first pass effect, and I'm choosing regularly in this perspective the Solumbra.
Okay, so Mikael, can you just go over some tips and tricks for a first pass reperfusion with Solumbra? What are the common errors people tend to make, and what are the things they should take care while going ahead with the Solumbra technique?
I think the first point is deploying the stent retriever. Just make sure that you are really covering all the thrombus, all the clots. And I used to do with the microcath when I think I'm beyond the clot, to do a run just to make sure that the landing zone is correct. And when I will deploy my stent retriever, I will cover all the clot. That's the first point. Regarding the contact aspiration, I go with the large bore catheter really against the clot. Usually the large bore catheter will intubate the clot. I will push through the proximal part. And then what's for me really critical is when you retrieve the stent retriever with the aspiration catheter, you have to go really slowly. But I think when you go too fast, I know time is critical. I know we want to open up the vessel as fast as possible. But these steps, you know, retrieving the clot, you must be really cautious and go slowly. Just think that you are taking out the clot with cautious, and if you go too fast, then you are at risk of, you know, breaking the clot.
So sometimes we get stuck at the ophthalmic bends, and any tips and tricks to prevent sharing of clot? One of the things you said is you go slow, pull the clot out slow. Is there any other? Sometimes it's too tortuous, or if there is a tight ophthalmic bend, is there any pointers for that?
So usually I try to put I use often the urine max, and I try to go intracranially. But again, when you go with the for example, your neuron max intracranially, you must be really cautious and go slowly. But if you go with your like the neuron max, if you go really distally intracranial, you give more support. You may rectify the arteries, but then it's easier to take out the aspiration cath.
Okay. Thank you very much, Dr. Mikael. So the other technique, Dr. Vipul, do you want to?
Yeah, so Dr. Raul, would like to know from you, I mean, so what are the key tips and tricks in getting the first pass reperfusion? This is what you have already talked about. And maybe we have already talked about changing the technique depending on maybe the blooming is there. But
Rajsrinivas Parthasarathy has stopped screen share.
Would you like to share with us?
As regards to stent retriever thrombectomy.
Stent retriever thrombectomy, first pass reperfusion, what can we do?
Sure. So
Raul Nogueira has started screen share.
Yes, we can see your screen. So
I just want to talk a little bit, because I think Mikael brought up a very good point, which is the double stent retriever technique. So perhaps we should talk a little bit about when to use that technique. It is specifically helpful, I feel, for the situation that Mikael showed, which is a clot that it's sitting in a bifurcation. In his case was the ICA terminus. Oftentimes this is a basilar apex, or more commonly it's going to be at the M1, M2 bifurcation. Okay, so the dual stent retriever technique, again, there are different ways and locations to do it. Here are several papers talking about it and cases from the literature. But it's just important for us to understand why this may work. Okay, it's always if you understand the mechanism of things, you will be able to use it better, and also the risks. Okay, so the first thing we have to understand is there is this concept of wet perimeter. This is physics, right? So if you have one stent retriever, this is the wet perimeter, right? Therefore, you have more friction between clot and blood vessel wall than interaction between device and clot. However, if you put 2 stent retrievers, you increase the wet perimeter, the interaction with the stent retrievers, and you decrease the wet perimeter with the blood vessel wall. Okay, so that's essentially decreasing friction with the blood vessel wall, essentially. The second point here has to do with Newtonian forces. When you have one clot, one stent retriever, you are pulling this direction. At the moment you do this, you have a vector that points in this direction, which is not aligned with the movement. You want to have the force applied in the same axis of the movement you want to create. And you do that a lot better if you actually have 2 stent retrievers, because the vector, the resultant vector, then balances things in a way that it's aligned with the movement. Okay, so these are the reasons why this technique works well. Mikael actually showed the way you typically do it. We actually optimize it by using 2 stent retrievers and aspiration. And I would like just to show how this is done. So here is a case of an MCA M1. This is what you like to call a diving MCA. This bad curvature of the MCA is a predictor of stent retriever failure. And these patients fail everything, fail 1 stent retriever, fail adapt, okay? Then what we did here is you did a double stent retriever in the MCA bifurcation, okay? Where you can see here first I put the embo trap there, then I partially recaptured the embo trap. I took a second microcatheter, and then I deployed a Trevo device. And you can see the construct here with the 2 stent retrievers. When you do that, you can remove both microcatheters, and then you can add an aspiration catheter in a blind exchange technique, because the stent retrievers are anchoring the wires, right? The wires can't move. So you can actually add an aspiration catheter as you remove the 2 microcatheters, and then you take it as far as you possibly can without doing a lot of force. The reason why this is important is when you have 2 stent retrievers there, there is too much interaction and pull on the brain. And you want to have a support here, okay, to change the vector. And we can talk about that later if you have time. If I don't have the support here, the vector is gonna be where I have the support in the balloon guide catheter, which is in this direction. I'm pulling the brain down. But if I have the support here, the vector is gonna be more aligned like this, towards the movement I want to create, okay? And then when I create this construct, I also can pinch the clot in between the 2 stent retrievers and then the aspiration catheter. So without that in place, we inflate the balloon, and as Mikael said, slowly you take the system out and you get your reperfusion, okay? You see here, this is a cone beam CT, no hemorrhage, and you can see the construct with the 2 stent retriever and the aspiration catheter. Here a more challenging case that was an M1 I could open, but then I had an M2 bifurcation occlusion. You see the inferior trunk here, but the superior division, which was dominant, was still occluded, right? So in this case, I put 2 stent retrievers at the M2 bifurcation, as you can see here, and then I add a 0.68 aspiration catheter, okay? One thing that it's important for you to understand, over time I understood that, you know, in general, when I'm doing single stent retriever technique, I want a lot of my stent retriever distal to the clot. But in these situations, I actually tend to have more stent retriever proximal. As you can see here, a lot of my stent retriever, right, half of it is actually not distal to the clot, because if I have too much stent retriever here going out the way in the M3s, it's too much pull in the brain. And that can cause subarachnoid hemorrhage, because you have two stent retrievers. So when you are using the double stent retriever technique, you use the aspiration catheter to give support and improve the vector, as opposed to pulling into the base catheter down. You are pulling towards the aspiration catheter, so improve the vector, but also you don't want a lot of stent retriever distal, because these are hard clots, okay? All what you need to do is create this construct here to pin the clot, and then you finish pinning it with the aspiration. And here is what happens. You pin the clot. You see two stent retrievers, the aspiration, or pinning the clot. These are typically not long clots that you need to have a lot of stent retriever out. And that's very important because, as Mikael said, the safety of this technique is not great. So if you have too much stent retriever distal, two branches, you are pulling too much. Then you can see here the before and after with full reperfusion, okay? We may or may not have time to talk about ICAD. This is a paper from Ur's group about calcific emboli. And I think Mikael showed the CT, and it wasn't the case in his case, but typically when you fail everything, it may be a calcific emboli. And our colleagues from Bern have shown, and I agree with that, that these are the worst case possible. For this calcific emboli, you see here, right, the same skull density, using the push and fluff technique with combined aspiration. Sometimes you can be lucky, but as you can see here, the double stent retriever technique may be very helpful, again, for this calcific emboli, because it may help pinching it. And finally, I think the best technique, and Mikael, this is probably what I would have done at your case at the end, is you just drop a stent. Okay, so you see here a calcific embolus. I try everything, including the double stent retriever, and I fail. What I did at the end is I drop a stent. So you see here before, after, and you can see what happens, the proximal and the distal portion of the stent, and you see the calcific emboli is trapped outside the stent, but that creates a channel that you can actually reperfuse. And get, you know, it's going to be typically a TK2B because you may have competitive flow. You still have a degree of stenosis there, but it's better than leaving the blood vessel closed. So to finalize to your question, here is the summary of how I approach the clots, okay? I still believe that a balloon guide catheter with a stent retriever is the best way to start. I'm using the combined technique, the Solumber technique that Mikael discussed, whenever I have curved vessels, or if my device looks pinch because it makes me feel it's a hard clot. And if I don't have a dense vessel sign, I tend to associate or just start with adapt. But then if I fail one or two passes of the stent retriever with or without aspiration, I do an aspiration alone technique without a stent retriever, because it works better for clots that are fibrin rich and the stent retriever cannot penetrate. And there are reasons why this alone sometimes is better than combining aspiration with a stent retriever. You can talk about that. Then if I fail, I may use a different stent retrievers because they have slightly different properties. And then I'll move to a double stent retriever technique, specifically if the occlusion is in a branch point, like the M1 bifurcation to the M2, so like a saddle embolus, a Y clot. But rescue stenting is something we all need to think about. And you should think about earlier if you think it's ICAD. And you should think about ICAD if you see ICAD in other branches, in the CTA or angiogram. If your patient is Asian, African American, diabetic, if there is no dense vessel sign or blooming artifact, okay? There are no reasons for cardioembolus, but the problem with the technique, it should be dynamic. You should start with a technique, but move to associating techniques or moving to different techniques as you go. And remember that rescue stenting is very powerful, as I showed, not only for ICAD, but also for a calcified embolus. So with that, I think we can discuss.
Wonderful, Raul. I mean, that was very nice. So suppose I say, when we talk about first pass, so you talk about using a stent retriever. You mentioned about push and fluff technique. You have also mentioned about where to place the stent retriever. We have talked about placing balloon guiding catheter and maybe going for a combined technique or having a Solumbra technique, having a digital aspiration as well. So these are all the factors which you think they play a role in first pass recanalization?
We believe so. We believe so. Again, we tend to use a balloon guide catheter in most cases, but again, the way you deploy the stent retriever is very important.
Yeah.
And the way you retrieve the system is very important. Perhaps I can show you this video here to help illustrating that. I don't know if you can still see my screen. I believe
yeah,
you
we can see it. We can see, yes.
So this is how not to do Solumbra, okay? So no balloon guide catheter. You can see that the aspiration catheter is a lot smaller than the M1, and you should never retrieve the stent retriever into the aspiration catheter completely because of this. You see? So it's very important that you do not fully retrieve the stent retriever in the aspiration catheter to avoid this phenomenon of clot stripping. So what we typically do is you bring the aspiration catheter where the occlusion is, and then we advance a bit and bring the stent retriever a bit, just to cover about 1/3 of the stent retriever, just about 1/3, okay? Because if you bring everything, you're gonna strip the clot out, just like that. So it's very important you don't do that, okay? The other thing you need to understand is when you do this, when you bring the stent retriever into the aspiration catheter, there is forward tension. And as you start to bring it out, sometimes it actually comes inside the aspiration and you have clot stripping. So you resheath about 1/3 of the stent retriever. And after you do that, you push the wire of the stent retriever a little bit, okay, to relieve the forward tension. And that will prevent the risk of the stent retriever coming to the aspiration catheter as you take it out.
Wonderful, wonderful. So if I have to summarize for a lot of our participants, so what Raul has mentioned, balloon guiding does make a difference. We know now, when we're doing a stent retrieval thrombectomy with balloon guiding, we like to place the stent a little bit distal from the clot, more of the stent beyond the clot. He has also mentioned about push and fluff technique. That means you push out the stent, which seems to expand it more and it gets more integrated with the clot. And of course, if you're using Solumbra, he has just very well demonstrated by that video how to take out that clot. So all those factors, they make a difference in first pass thrombectomy. Raj, do you want to add something?
No, that's fine, sir. I mean, I think he had beautifully covered how to go from one technique to another technique, not to stop just
so maybe, yeah, Dr. Raul, you can just show us a couple of slides of push and fluff technique so that people understand.
So one common mistake that people do is they just unsheath the stent retriever, okay? And you should never push a stent retriever out because you can cause vessel injuries, particularly if you are up against a bifurcation or a curvature. So it's always important to study your landing zone with a little microcatheter injection, okay? But first you unsheath the stent retriever, but then once it contacts the wall and anchors, you have to push it out. There is no bringing the microcatheter back anymore. There is only pushing it out. And you can watch the stent retriever being deployed to make sure it's not collapsing on itself. But if you don't push it out, you stretch the stent retriever and you have something like this. Versus if you push it out, you have an active deployment where you open the stent retriever better. You can see here that you are opposing the blood vessel wall and you are opening the struts of the stent retriever a lot better if you push it out. So if you have a hard piece of clot, it's not gonna get in a small unopened cell like this, right? But if you open it nicely and you are forcing it against the clot, it's gonna be incorporated. So that's the importance of the deployment technique, okay? The other thing you mentioned is use the long stent retrievers. We stop using the 420 stent retrievers. You only use 440s, 430s, depending on the brand, okay?
Right.
And there is no point in deploying your stent retriever proximal to the clot. That's not doing anything. You want the bulk of your stent retriever distal to the clot.
Wonderful. I think that overall covers the technique pretty well, and we'd love to keep hearing from all of you, but I think Raj would like to go to the next. He had arranged a lot of interesting more questions. Let's go to the next topic. Raj, I think Dr. Raul, you'll have to stop the screen sharing, and then Raj, you can bring it in.
Raul G. Nogueira has stopped screen share.
Raj, you have to unmute yourself.
Rajsrinivas Parthasarathy has started screen share.
Raj, you have to unmute yourself.
Okay, so now we're going to the next.
Yeah. Go back to this previous slide, I guess. So we are coming to intracranial atherosclerosis now, right?
Yeah. So we are moving on from the clot and the techniques, and now we'll go focus on the parent artery. So the first question would be on secondary prevention, and this would be to Dr. Fischer. So if you have a patient who has got symptomatic atherosclerotic disease, intracranial, and what would be your policy on medical therapy, and when do you consider stenting in this set of patients? And what do you think the future perspectives will be, and how things might change in future?
Thank you very much for asking this really important question. You know that we know very well from the previous experience that antiplatelets are working very well in patients with intracranial atherosclerosis. So our first approach in these patients is whenever possible, we try to give these patients double antiplatelets, because we know that double antiplatelets and statins are very helpful in these patients. Nevertheless, we know from randomized trials, they unfortunately failed to prove that stenting in intracranial atherosclerosis is beneficial. But this does not mean that there is no role of intracranial stenting, because if a trial has not proven the efficacy of a treatment, does not mean that it doesn't work. Probably also the trial has not been designed the right way. So that's the reason why our approach is normally here in Switzerland that we really start with double antiplatelets, and if the patient has recurrent symptoms despite antiplatelets and statins, we consider stenting. We always do this in an approach. We have a neurovascular ward round several times a week where we discuss these critical cases, neurointerventionists with neurologists, and then we come together and we try, as Raul already mentioned, to individualize the treatment approach in these patients. What is also very important is, imaging consideration and also the etiology of the recurrent vascular events. Was it an embolic event, or is it a hemodynamic event? And unfortunately, in the trials on intracranial stenting, there was no difference whether this was an embolic event or a hemodynamic event. And therefore, I think that strongly matters. So if you have a patient with recurrent events with a high-grade intracranial atheromatosis, who is under double antiplatelet and he makes recurrent events, then stenting has to be considered, but it has to be done by a very experienced people, and the anatomy and the condition has to be evaluated carefully.
Okay, that was very interesting. So, Dr. Fischer, how long do you continue double antiplatelets in these patients?
Well, that's a very good question. Honestly, I would like to give you randomized evidence, and honestly, I cannot, because it's interesting to see all the trials comparing antiplatelets on a dual antiplatelets on the wrong run. They were negative. Nevertheless, again, also here, I think you should stratify your secondary prevention by the underlying etiology. So I'm pretty much convinced that if you have patients with a high-grade intracranial atherosclerosis, the risk that these patients are having other ischemic events is much higher, that they have a bleeding complication. So in these patients, probably we even have to consider to give dual antiplatelets on the long run. Normally, we say 3 to 6 months, not more. But if you have a high risk of recurrent ischemic events, we also have patients who are on a longer therapy with antiplatelets. But this is not randomized evidence. That's just experience.
Oh, wonderful. I mean, that was nice. So,
yes. How long are you keeping your patients on double antiplatelets after a symptomatic event?
Yeah, that's a very good question. So currently, we keep them at least for 6 months to 1 year. And then we reevaluate. It very much depends whether the patient has recurrent events. We also often perform follow-up imaging whenever we can, MRI in these patients. And if you have the impression that these patients have a risk of recurrent emboli, then we continue. But as already mentioned before, there is no randomized evidence that you should give dual antiplatelets on the long run, but in certain selected cases, I think it can be justified. What about you, Raul?
Yeah, I share the tendency to use antiplatelets for longer. I think you see, if you look at Sempri's, in the longer term, so you had that great early 3 months or so, right? But as the antiplatelets were discontinued, those patients is starting to have, again, a lot of events. So I tend to do the same. I actually have many patients on long-term dual antiplatelets, specifically those patients that have poor collateral. So
yes.
You can imagine if the vessel occludes, right? I'll give you a good example. A patient that has a basilar stenosis that is severe, and has no good PCONs or good cerebellar collaterals on angiogram, those are people that I will never take off antiplatelets unless they have a bleeding event. So I think thinking about the worst case scenario, which is if this vessel were to occlude, what will happen to this patient, really helps me making that decision. And I think collateral flow analysis is probably one of the good ways to make that decision, as well as obviously the bleeding risk.
Yeah, and again, it also goes in the same direction. If you have no backup, then the risk of having a severe ischemic stroke is much higher than having a hemorrhage. So it's the same as you mentioned before. If you have a high NIH, there is nothing to lose. If you have a low NIH, there's a lot to lose. If you have a high-grade intracranial stenosis with no collateral flow, then you have quite a lot to lose. And these are the ones where we tend to be more aggressive.
Great. I think terrific. That was a nice discussion. That's why we asked this question. But these are dilemmas everybody faces day to day. So Raj, I think Raj would like to present a few dilemmas which arises in endovascular management of these patients. And after that, this will be followed by presentation by Dr. Raul and Mikael. Yeah.
So this is a 65-year-old male with basilar occlusion, came in with quadriparesis. On CT angio, you clearly show the basilar is occluded and there is a narrowing of the artery just proximal to the occlusion. In this particular instance, we went in, we did a solitary thrombectomy. You see clearly there is a significant stenosis post-thrombectomy, but we decided to just give a GPI, a GP2B3A. The artery remained open and we stopped at that. So the next patient is a patient, 63-year-old male who had an aortic valve replacement on Coumadin, INR of 2.5. He had right-sided hemiparesis. On the perfusion imaging, you see there's a lot of penumbra there. Again, in this particular patient, first pass didn't work, therefore the solitaire was deployed, and you see that there is the post-CT looks quite good. And the last patient is a 80-year-old female, right-sided weakness with aphasia, presented within 1 hour of onset, and therefore the patient thrombolysis was given. If you see the CT angio, there was an abrupt cutoff. There was no tapering that you could see. There's an old stroke here, no blooming, and no definite hyperdense sign on the CT. In this particular patient, the first we went for a solitaire thrombectomy. You clearly see there's some tapering here. With the first deployment of the solitaire, good antegrade flow, remove it, the artery gets occluded. And then we went ahead and did a balloon angioplasty, and we just got a TK2A flow. This is an 80-year-old lady who's got IV TPA on board. In this particular instance, we decided not to deploy a stent. And this is the post 24 hours. There was no increase in core volume, and she gradually improved over a period of 3 months.
So the whole issue, I mean, and we'd like to Dr. Raul to present on this, that, you know, when we come to intervention in these patients, do you have imaging clues, or we don't know that? What is the initial thrombectomy technique? And like we showed a case of drug or a stent or just doing angioplasty. And even if we do stent, which one and how to manage these patients? I mean, I think you can start your screen sharing.
Rajsrinivas Parthasarathy has stopped screen share.
Okay, and I think Mikael may want to talk. I don't know if he wants to talk first. I'll be happy to talk now. I just want to make sure he covers this topic.
Raul G. Nogueira has started screen share.
So we can talk a little bit about some of the key principles of endovascular treatment of intracranial atherosclerotic disease in the setting of a complete occlusion, the setting of acute stroke. So I think the first thing you all need to understand is this is not a coronary artery, right? You need to understand it's a different territory. It's more prone for damage for several reasons, including the fact that we don't have an external elastic lamina in the intracranial arteries, and the media, it's thinner. So again, we have to be a little more careful. The other thing you need to remember is that not all stenosis is ICAD, right? So you need to think there are many other causes of vascular stenosis: dissection, moya-moya, vasculitis, RCVS, spasm, intravascular lymphoma, endarteritis from endocarditis, that may not be ICAD. And obviously, the common problems like a partially occlusive thrombus sometimes can mimic ICAD, and underlying vasospasm can mimic ICAD during the treatment. You may have an occlusion, and then you treat that occlusion, you remove the clot, and then you have that narrowing, and you think it's ICAD. Maybe that's just vasospasm from the mechanical manipulation, and that's why I like using vasodilators to prevent that from happening. Sometimes it's hard to know. So when you should suspect ICAD, we have this little guide that you have to validate still. Again, you look at the race of the patient, diabetes, absence of hyperdense clot, as it was discussed just now, and blooming artifact helps, evidence of multifocal ICAD. If you have calcification at the site of the occlusion, I think that helps quite a bit, but it's quite rare. And seeing multi-vessel ICAD on CTA or DSA is very helpful. The tapering or pencil-like type of occlusion, as opposed to a meniscus or abrupt occlusion, helps on angiogram. And we will talk a little bit about the truncal type occlusion that was described by our colleagues from South Korea. What you see here in the truncal type occlusion, okay, is essentially the sparing of the MCA bifurcation. And that tends to be more common with intracranial atherosclerotic disease, as opposed to the non-sparing, the brink site occlusion, where you don't see the MCA bifurcation, tends to be more common with embolic events. So those are little clues for ICAD. On CT perfusion, you like to say when you see a lot of blue, a lot of the Tmax greater than 4, lesion in detriment of a Tmax greater than 6, that may help with the ICAD diagnosis, but it's pretty difficult, okay? The implications is that these patients have worse outcomes, okay? And it's not that easy. I'm not gonna waste time going over these papers, but the bottom line is the outcomes seem to be the same, but when you adjust for age, the outcomes are worse after ICAD, okay? An important message here is there is no data to say that the use of glycoprotein 2B3A inhibitors increases the chance of symptomatic intracranial hemorrhage during endovascular therapy, even if you use TPA. And this is a paper from South Korea about that. So the safety of using tirofiban seems to be pretty decent, even with the use of TPA. Okay, here are other papers. This is a very nice paper from China about intracranial ICAD, South Korea. I'm just gonna move to the more important discussion here. So what Urs just discussed was the intracranial atherosclerotic disease that comes with a TIA or a non-disabling stroke, a non-LVO stroke. We're gonna be talking here about a different situation. It's important that you understand that SEMPRIS and VISIT were trials for the stable angina of the brain. We're gonna be talking about the ST elevation and mine of the brain, the acute occlusive disease. So these trials do not apply for the acute LVO cases, okay? And here is how I would propose us to treat this situation. First thing, you have to suspect, right? And that's why I spent time talking about the demographics and the imaging when you should suspect ICAD. Why? Because you should immediately load the patient with oral antiplatelets. And I prefer to do Brilinta 180 and aspirin because Brilinta is a lot faster than 600 milligrams of Plavix, which is probably our other alternative. The second one being Prasugrel, I think is the other good alternative, but you wanna do this fast, okay? If you don't have time for oral, you're gonna have to use intravenous. But when you do your procedure, even if you think it's ICAD, I don't think you should start with stenting. You should first debulk the lesion, remove the clot, and delineate the lesion with a stent retriever. So you suspect, you debulk, you then don't necessarily put a stent. You prevent reocclusion after you remove the clot. If you have flow, you have flow. You may not need stent. And I like the case that Raj showed where he actually just opened the vessel, there was reasonable flow in the basilar, and he did tyrosine and didn't put a stent. There was no need, you're only increasing risk. So many times after you remove the clot, you just need to prevent reocclusion with IV antiplatelets unless you have oral antiplatelets already acting and on board. However, if you do that, if you don't put a stent, you have to observe. You shouldn't stop the procedure. Wait 15, 20 minutes because that vessel may go down over time. It's a dynamic process, okay? So open the vessel, IV or IA tyrosine. I tend to do pretty close to the full bolus and observe. Then you rescue, you put a stent, and I almost never do angioplasty in these patients. You can talk about why, okay? I do that if there is critical residual narrowing with slow digital flow, right? If there is hemodynamic problems, if there is plaque dissection that is significant, if there has already been a previous stroke in the same territory, because I know that's a bad lesion, I may just well treat it now if I can do that. Mostly if my cord is small on baseline imaging. And many times, stenting is not needed in the acute phase, right? So again, the rescuing is an additional maneuver that sometimes is not necessary. So sometimes just observing and seeing that things are stable is good enough. But again, sometimes you have recoiling of the vessel, reocclusion, and you have to treat the patient. So I would like to dedicate some time now to talk about some technical considerations. Again, the idea being you have an occlusion, you debulk that occlusion, you give tyrosine or other glycoprotein B3 inhibitors, and you only rescue if you need to. And the reasons for that are well depicted here in this paper from South Korea. Again, just a thrombectomy in ICAD, it's not an option. If you don't load those patients on fast-acting antiplatelets, you're gonna have a reocclusion, okay? But even if you do that, you may need to rescue the patient sometimes. Here are papers that discuss the process of embolic strokes versus ICAD for your interest. But again, rescue stenting is something you should have in your armamentarium. As I said, stent river, associate aspiration, aspiration alone, double stent river, intracranial stenting. But if you think as I had, intracranial stenting becomes the second modality after a stent river. Okay, these are papers going back way from more than 10 years ago now about rescue stenting in stroke. I think it's a well-described modality. This is a great paper from China where they use rescue stenting and they compare the patients that they give up versus the patient that they stent. Again, the rate of good outcomes, it's not great with stenting. It's 36% as opposed to 50 to 60% in the general population. But it's a lot better than if you didn't do the rescue stent and you left the vessel occluded, as you can see here. So one of the common questions is, what kind of stent I'm going to use? How do I decide? You have to understand the Mori classification. You should all read this paper from Mori. This is a paper from Professor Miao in China, where he tells how he thinks about this. And this is a schematic way that I use to decide the type of stenting I'm gonna be using. Balloon-mounted stent or a self-expanding stent. First of all, the balloon-mounted stents don't go below 2 millimeters. So if the vessel is bigger than 2 millimeters, you can use a balloon-mounted. However, if the vessel is less than that, you can only use a self-expanding stent. Very important, the balloon-mounted stents are cylinders. They don't taper. They don't accommodate the vessel. So you look at the landing zones, proximal and distal. If they are about the same, yes, you can use balloon-mounted. But if there is a mismatch, if the vessel tapers, you can only use a self-expanding stent. Otherwise, you're gonna have a proximal shelf in the balloon-mounted, which will lead to acute stent occlusion. Lesion length. It's a lot easier to navigate a balloon first and then place a self-expanding stent than to bring a balloon-mounted stent. Why it's important? Because you are not going to be able to bring a 20 millimeter balloon-mounted stent in the M1. Okay, so for longer lesions, okay, typically greater than 10, 12 millimeters, probably self-expanding, it's a better choice because it's hard to navigate long balloon-mounted. If you only have balloon-mounted, don't try to take a 16, 18 millimeter stent to the M1. Take 8 stent, deploy it distally, then come with another 8 stent and overlap, telescope, okay, proximally, because it's very hard to bring long stents in the M1 that are balloon mounted. Finally, if the segment is straight, balloon mounted does very well. However, if there is high tortuosity, use a self-expanding stent. So this is a good diagram on how you can decide one versus the other. In my opinion, whenever I can, balloon mounted is better. It's very cheap. Coronary stents in US, they are less than $1,000. These guys, self-expanding, they are over $5,000. So it's over a 5-fold difference. Sometimes it's a 10-fold difference in price. And the results are better, at least the technical appearance with balloon mounted. A few things you should understand. There is something called about chronic outward force, okay? Which when you put a self-expanding stent, it is gonna keep exerting that outward force very long. And that correlates with in-stent stenosis, okay? But one way of increasing your chronic outward force is to oversize your stent. What I'm trying to say is you can get a aneurysm bridging stent like a Neuroform Atlas or an Enterprise, oversizing a vessel and get a pretty good radial force, okay? And this is what I show here. In this scheme here, I'm comparing Neuroform, okay, in a 4.5 vessel versus a Neuroform in a 2 millimeter vessel. And you can see here that if I get a small neuriform, you see the color here, this is a small neuriform. Oh, it's a big neuriform, I'm sorry, it's a 4.5. But if I put that neuriform in a 2 millimeter vessel as opposed to a 4.5 millimeter vessel, I increase the radial force by 4-fold. And I get that neuriform to behave like a wingspan, okay, in a size vessel. So a 4.5 millimeter neuriform can have the same radial force of a 2.5 millimeter wingspan if you oversize it in the MCA. We now have 2 millimeters balloon mounted stents. It's called the Onyx Resolute. It's drug-eluting. It's a great choice for this case. So now let me tell you a little bit about technique. Here is a patient that came, NIH stroke scale fluctuating 8 to 11. We saw the case and we look at the image. So you ask the outside hospital to load the patient. And you see here the CT perfusion already showing a core in the ACA, MCA area here, but a larger area of hypoperfusion. You can see here the CT perfusion. You had this case, you had an ICA occlusion, supraclinoid ICA. First thing you do is you cross the lesion, you check our landing zone, as you see here, for a little microcatheter injection. We then deploy our stent retriever, okay? That allows us to debulk the clot, but also allows us to study the lesion, okay? So you can see here with the stent retriever in place, I can measure my vessel, I can study the area of maximum stenosis, but more important, after the stent retriever, the vessel is open, as you can see here, essentially a very good TK2B. However, when I look at that vessel, okay, post-treatment, you can see there is still a significant area of stenosis with a very ugly looking plaque, okay, that it's dissected. You can see a little flap below here and a pretty critical stenosis with a complex plaque. So this is a case that you're gonna treat acutely. We recross the lesion always with a loop, with a jade micro wire, okay? You're gonna use a micro balloon mounted stent. In this case, it's a 3.5 by 9, okay, which was based on my measurements. And you're gonna take that system through an aspiration catheter type of catheter. Why? Because that aspiration catheter, I can take it all the way to the stenosis. But it's not a true aspiration catheter. It's a flexible distal access catheter. I like using the 5 max DDC. It can't be a regular aspiration catheter because they are too long and they don't allow for the stent to come out. It has to be 125 centimeter or less. But the bottom line is this: you really want to get, okay, and kiss the stenosis with it, because your next thing is gonna be to bring the stent through the aspiration catheter into the stenosis, okay? So it's very hard to make this bend with the stent only. But if the aspiration catheter is there, if the distal access catheter is there, it becomes then very easy to navigate it through these bands, okay? Because you are doing it not through the vessel, but through the catheter, which is a lot easier. You then remove the forward tension and you slowly, you look at your lesion, you slowly inflate, and then I tend to, you have to size the balloon mounted stent to the size of the vessel. There is no undersizing here. Then you do your angiogram, good reperfusion, and again, you are not done. You wait 20 minutes to see if there is acute stent thrombosis, okay? In this patient, there was Brilinta and aspirin for a while, wasn't a problem, but then you have to make sure, again, that that stent remains open 20 minutes later, okay? Which was the case here. So quickly here, you can only see on the DWI that initial stroke, right? That you saw on the CT perfusion. And you can see here again, first thing, this is a different case in the ICA. ICAT occlusion the other side in this case. First thing you do, you debulk, then you look at the lesion, right? You treat, you prevent with glycoprotein 2B3A inhibitors or do antiplatelets, and you observe. But in this case, again, critical stenosis, plaque dissection, ulcerated plaque, you're gonna have to treat. And then you see the treatment with a balloon-mounted stent. But you can see that the debulking of the clot really helps preventing acute occlusion of this stent. Because if I had just stent this, I would be stenting the plaque and the clot, and this clot will serve as a nidus for acute reocclusion, okay? It is a different case. It's a balloon mounted in an M1. I'm gonna go a little quicker here just to show the case. This patient had a previous stroke in the M1, which tells us that the patient probably had a stenosis there up front, right? So here is the stent retriever. You can see the area of stenosis. Again, she had a previous MCA stroke, like one of the Raj's cases. This is post-revo. Doesn't look bad, okay? But there is still a residual stenosis. And this patient, again, this is the second stroke. Very small stroke on baseline image, so why not to treat here? And here is what I did. First thing that I did is I took my 5 max DDC all the way to the stenosis. Then through it, I advanced my balloon mounted stent. Okay, I look at where I am, and then I slowly deploy my stent. And then I do my angiogram with a good result. I observe it for 20 minutes, make sure there is no clot formation, and I see there is a good result. But again, why did I use a balloon-mounted stent here, guys? No mismatch in the length zones. You see, proximal and distal is the same vessel diameter in the M1. It was a short lesion, and it's in a straight segment. And the degree of proximal tortuosity wasn't bad. So great case for a balloon-mounted stent, right? So that's how you need to think about, you know, one versus the other. And again, the delayed 20-minute angiogram before and after. And again, the different steps. Here you see the follow-up DWI with very little embolic strokes. How about self-expanding stents? How you do that? And the way I'm doing that has changed over time. This is a 57-year-old, and IH stroke scale is 16, M1 occlusion. A lot of these patients will come with delayed time of symptoms onset. They tend to have good collaterals, so they hold the penumbra for a little longer. And here you see the occlusion of the vessel.
Dr. Raul, can I interrupt? I think Mikael has to leave in another 10 minutes or so. Is it okay if he presents his cases and then I'll come back to where we stopped here, where you stopped?
Sure. And I think we have made a lot of the points I want to make. I'm happy to.
Or if you want to just finish this case, you can just finish this case and then Mikael can go ahead.
Sure. So here is a self-expanding stent, okay? And what you typically do in these cases, okay? And the reason you use it is, again, you can see there is a mismatch between the landing zones where, you know, it's smaller here than here. It's a curved segment and it's a long stenosis, right? So you want to use a balloon-mounted stent. So typically you're going to do a balloon angioplasty first. You have to do that using, so first you do the debulking with the stent retriever. You cross with the J-wire, right? And then you do your balloon angioplasty over an exchange length wire. And then you have to bring a microcatheter and deploy the stent. We are doing that in a different way now that it's a lot simpler. If you have time, you can talk about that a little later. Okay, so let Mikael proceed now.
Dr. Mikael, I'll request
Raul
you to present all your...
has stopped screen share.
Thank you very much. I apologize because I have to leave. Actually, I'm on call and we have.
Of course. So if you can quickly present your access cases as well, it's very interesting. We would like to know that. I know it is. We're moving away from the main topic here, so you can present your ICAT followed by the access cases or whichever you want to show, depending on your time.
Yeah, I'm going, really fast with the access case. I'm sorry.
Sure. Go ahead.
Now.
Go ahead with the access cases, yes.
I don't know if you can see.
Michael Mazighi has started screen share.
Okay.
Yeah, great.
So this is the case of a 92 years old female. Actually, you will see two similar cases regarding access issues. So this is a woman with, as you can see, right MCA stroke. She's NH20, and you can see here a faint hypersignal on the diffusion imaging, the blooming effect of the clot on the right M1 segment, and when we look at the MRI, we can see that the occlusion. The patient receives TPA, and we go. Stuck there. Sorry. Yeah, we go to the cath lab, and as you can see, there is a tortuous aortic arch. We make a run and we confirm the M1 occlusion, but still we are not able to go up with our guiding cath, which is here a Neuronmax within the right carotid. And so we decide to move to a carotid puncture. So in this situation, we move from a conscious sedation to general anesthesia, put a stiff wire, and then our guiding catheter to perform the thrombectomy of this M1 occlusion. And in this situation, we went with a Salombra technique with A68 and a Soluteur, and we succeed in a TKI 3, but the patient did not so well at 3 months. Another similar case, but on the other side, 92 years old female, also severe stroke, NH19. She also received TPA. You can see here on the other side the stroke on the DWI lesion. On the MRI, we can see the carotid occlusion with the MCA. Here we can see that there is a tight stenosis with a tandem occlusion intracranially. And again, the same situation with very tortuous anatomy regarding the aortic arch and the common carotid. We failed to catheterize, and we decided to move to a carotid puncture. What we did, in this situation, we failed to go within the ICA, but what you can see here is a carotid dissection. Just to underline the fact that with this approach, i.e. the carotid access, you are at a risk of carotid dissection. So with this unfortunate failure, we decide to closure the artery, and we double checked with the catheter we had with the femoral access, and you can see here that despite the closure system, it was not doing the job. So we had extravasation, we did manual compression, and you can see here the carotid dissection. So just to really fast, I'm sorry, but 2 cases to show that it's feasible, the carotid access, but it's still risky with 2 main issues, which is the carotid dissection and of course the neck hematoma related to the access. I think in this situation you may prefer general anesthesia than conscious sedation, or any situation that may be associated with patient movement that will bring more difficulties to this type of access. So in this situation, I think we have really to consider the benefit-risk ratio of the stroke perfusion in regards to the carotid puncture and probably consider a radial approach before. Thanks for your attention.
Very nice.
Michael Mazighi has stopped screen share.
Very nice and challenging cases, Michael. I mean, these are the nightmare ones. So yeah, and as you mentioned, probably radial approach is going to go. And how do you close these direct carotid punctures if you have done them for acute stroke? What do you do later on?
So usually we use the system that we usually use for femoral access, like FemoSeal, for example. That's the system that we use to close the carotidity. It works, not in the last case, but usually it works, yes.
All right. Okay. Raj, you have to unmute yourself.
So thank you very much, Mikael. Thank you for coming in. I'm sorry you have to leave early because of your commitments. Thank you very, very much. You've done amongst your busy schedule, you've taken time out. It almost is 2 hours now, and thank you for that.
My apologies again, and thanks a lot. Thank you.
Okay. Thank you.
Bye-bye, Mikael.
Bye-bye.
So can I just, before going on to Dr. Raul's presentation, can I ask Dr. Fischer about, so we have discussed about the stents, thrombolytic drugs, we have discussed about antiplatelets. So we have to discuss complications as well. And one of the dreaded complications is intracranial hemorrhage. So what are the take-home messages or the key pointers that Dr. Fischer, you would like to communicate in patients, particularly if they are having a bridging thrombectomy, or if they have to put in a stent, give GP2B3 antagonists? So what are the key red flags that you look out for and be careful about in these patients? You have to unmute yourself, sir.
Yeah, thank you very much. I mean, one of the most important thing is, and I think it also nicely fits what Raul said before, you always have to balance the risks and benefits of an intervention, and you have to consider in a certain type of patient, what is his individual risk of having a complication, and what is the potential benefit if you proceed with the intervention. And so the risk and benefit ratio, they very much depend on the situation. If you have a patient, for instance, with a lot of microbleeds, he has a large vessel occlusion, and you know that the main target is opening the vessel, and you know that thrombectomy will probably have the biggest effect on recanalization rate, and the additional administration of TPA, which is obvious by randomized controlled trials, in this particular situation is not probably very helpful and increases even the bleeding complication, then you should consider where in such a situation where the bleeding risk is very high due to the high amount of microbleeds, whether you should skip it or not. So you have to tailor your decision based on the prediction. And we know what are the main predictions of intracerebral hemorrhage. We have imaging features. I think imaging is very important. For instance, we know that patients with a very low aspect score, with a large vessel occlusion, we know that the hemorrhage rates, if you give TPA, are higher if the aspect score is high. So we know that NIH matters. We know that diabetes matters. We know that age matters. And so there are different risk factors. Also, if you are already taking vitamin K antagonists, we know that the risk of having a bleeding complication is high. Also in patients with atrial fibrillation caused strokes, so big cardioembolic strokes are also a risk factors. And especially if you have a patient with an endocarditis, you know that you have a very increased risk of bleeding complications. On the other hand, we know that other patients don't have a high risk of bleeding complication. These are the ones with normal brain tissue, the young ones. So in these patients, the risk of producing a hemorrhage is very low. So therefore, there is no answer which fits to all patients. And you really have to tailor your strategy. You have to individualize your approach. And you know, everybody's talking about precision medicine, and that's basically what we are doing. We have to do precision medicine in stroke. And so you have to take the best available information, and then you have to translate it to your individual patient and then you have to tailor your treatment approach. That's, I think, my final conclusion.
Okay. So would you consider thrombolizing in patients where you suspect ICAD or a tandem, where we have to put a stent or we have to give DP2B3A? Would you really bridge those cases, or would you avoid bridging in those set of patients?
Well, it's a very good and challenging question. I always try to answer this question based on randomized evidence. The problem is that we do not have this randomized evidence. And but what we know is, if you have a huge clot in the internal carotid artery, and if you have a tandem occlusion with a very high likelihood that you have an underlying atherosclerosis and you have to stent, we know that the chances of recanalizing this vessel with TPA is very low. And on the other hand, if you want to put an emergent stent in this situation, you want to give antiplatelet and eventually also clopidogrel. So we know that this probably is much more important than TPA. So in these situations, we consider skipping TPA, starting with thrombectomy, then we stent, we give aspirin and clopidogrel if necessary. And, you always have the possibility, and I think that's something which has to be discussed in the future. Should you not give intraarterial lytics after the intervention in these situations? For instance, if you have recanalized the M1 and you still have a TK2B reperfusion with distal clots, we really have to think whether we should, just do the things the other way around. Direct mechanical thrombectomy first, and giving lytics afterwards in patients with distal emboli. And I think that could be something which is which could be very interesting. And I'm also very surprised by, that the results of the ESCAPE NA1 trial are very interesting, because they have shown that neuroprotection works in patients without TPA, but not in those with TPA. And that's also something which we have to consider in the future. In patients where we have a low likelihood that TPA really has a major additional benefit, should we give NA1 in these patients? So these are very important questions which cannot be answered by randomized evidence now, but there are a lot of things which we have to do for the future.
Yeah, I would agree with you, Dr. Fischer. Although there is no randomized evidence, certain conditions you have to individualize, and like tandems, suspicion of ICAD, I may withhold, although there is no evidence for that. I completely agree with you.
But that was wonderful ideas, talking about neuroprotection, giving it afterwards. And, interesting, is a very fast evolving field, and let us see how it goes. So that was absolutely.
I think one of the things that's very important about the bridging versus not is where the patient is, right? And maybe Urs can talk about that as well. One thing is if the patient comes straight to your hospital, right? Versus the other thing is if the patient is 1 to 2 hours from your hospital. Can you talk a little bit about that?
I mean, that for me, it's obvious. If you are in a remote area, and if you have LVO, and if the patient is IV TPA eligible, I'm very much convinced you have to give TPA. I mean, but if you are in the in-hospital set, I think that very much depends. If you're in a setting where you have access to immediate thrombectomy, where you can, perform the thrombectomy very fast, then it's a different scenario. But if I would never leave a patient untreated in a scenario where you need at least 2 hours to bring the patient into the next stroke center.
And you don't consider 0.6 in bridging, right, alteplase?
Well, good question. Honestly, when we started, we started to perform endovascular procedures in our institution before even we had randomized evidence. And at these times, we always gave the 2/3 dose of TPA initially. So in 2006, 2007, 2008, in these days, we were giving the 2/3 dose. Then after a while, and also in these days, we were not even sure whether we should give TPA at all, or whether we even increase the risk, the hemorrhage risk. There was no evidence. And but after the trials, it was obvious that we have always to give the full dose, because that's standard of care. And therefore, we stick to the rules and we give full dose. However, that's also something which has to be addressed in the future. And the Japanese, they're giving 2/3, but so the body weight of the Japanese is a little bit different, and you cannot compare these with our population. But it's an unanswered question.
What is your take in the Enchanted trial results?
Yes, that's a very good question. I mean, the Enchanted the Enchanted trial was not showing that the skipping or the reduced dose is non-inferior to the full dose. Nevertheless, the bleeding complications were lower. So in certain situations, we consider this, especially if I do have a patient with, with a high burden of microbleeds. So if it's more than 10, 20, then it's something which we consider. But honestly, in these cases, we often go, if possible, for direct thrombectomy, and we then consider giving intraarterial TPA or urocanase afterwards, if there are distal emboli.
I think, thank you very much, Dr. Fischer. I mean, you've been also patiently, you've made this possible. And so I think we'll continue with Dr. Raul's ICAD talk. I think this is something in India, it is important because we feel we do see a lot of ICADs with acute occlusions. Can I ask Dr. Raul to slide share?
Raul G. Nogueira has started screen share.
So just before you go there, I just gonna show a couple of slides on the access issue. Mikael showed a couple of cases, and I think it's just important that we try to optimize the technique. There is no question that carotid puncture is an option. There is also no question it should be your last option. You should try radio approach first for the reasons that Mikael explained. But I think it would be nice to talk about how to best do it, okay? So first of all, in the vast majority of the cases, obviously you're gonna try transfemoral approach first. And with a VTEC catheter or a Simon's, most of the time you're gonna be able to engage the arteries. You may not be able to take your guide catheter up, right? But because you can engage the artery, right, this can give you a roadmap. So this is a case that was very difficult. I could not take my balloon guide catheter. I tried a Neuron 088. I could not make this curve, even though you can see I was able to take the wire very, very high. There are several ways to try to deal with the situation, but we decided then to go for carotid puncture. So a couple of things here. In order to avoid that problem of dissection, okay, you want to do this in the most guided approach. So you have your catheter there, you can obtain a roadmap, right? And you also should do this under direct ultrasound guidance to have a single wall puncture with a micropuncture system. And these are things that will minimize the risk of this procedure, okay? So again, the puncture should be relatively low, so towards the mid cervical common artery, okay? And you can do it under dual guidance with a roadmap and ultrasound. And in our experience, that helps always getting that single wall first attempt and avoiding problems, and use a micropuncture system. Here is the setup. You would then just put a 6 French pinnacle sheath, and then through there you can put your aspiration catheter, stent retriever, and then do your treatment, okay? This is a paper that I would recommend you to read. It really depicts well the best way to do your puncture, some of the basic principles on how to do it, okay? But more and more, first of all, no one should be proud to have too many carotid punctures. That means you are a bad angiographer from the groin, right? And you probably want to do the radio approach first, if it's possible, because it's probably safer. So going to the radio approach, here is just a quick example, and it can really show how much easier it is to come from your right radio and get your left common. In many of these bad situations, here is essentially one case, and here is a paper showing the technique you all should read. But again, I think it's important that you understand the technique exists, but how to best perform it and take advantage of all your guidance, roadmap guidance, ultrasound guidance, micropuncture technique. It is not hard to get into the vessel. I have never had a dissection get into the vessel. Haven't done many of them because we really try to optimize transfemoral and transradial technique, but it's not unsafe to get in the carotid artery. The problem is actually getting out of it. It's not getting in, right? And then some people use closure devices. We only use closure devices if the patient got TPA, otherwise you do manual compression. And what I do when I'm getting out is I keep that VTEC catheter at the origin of the vessel. So I can do my manual compression, and then before I get out, right, I do an angiogram to make sure there is no residual leak or extravasation in the neck, okay? Same thing if you just use a mechanical closure device. So in the rest of the time you have, I'm just gonna show you a couple of cases of intracranial atherosclerosis to finish it. We showed this case, which is a self-expanding stent proximally, but I want to show a more challenging case where you really can treat very distal lesions, like this case, 77-year-old lady, came with an IH stroke scale of 14, but with very severe disability, okay? And despite being loaded with Plavix and aspirin, okay, she wasn't therapeutic. So she was a patient that we still had to give more treatment. First thing here is the baseline image is good. You can see some old strokes, which typically happens when you have ICAD. And you can't quite see an occlusion on the CTA, which was surprising. You see that big area here of basically what looks like oligemia, but she has an NIH of 14, tortuous anatomy, and here is the situation. You see the vessels are tortuous, ICAD everywhere, and you don't clearly see what you were expecting with an IH stroke scale of 14. There is no proximal arterial occlusion. But when you look at the lateral angiogram, what you see here is this huge area of hypoperfusion, right? And when you find that area, we know there is a culprit and it's not proximal. So you have to spend time to really do good angiograms and find your more distal lesions. And if you look here, you see that you have your M1, your M2, and then the M2, M3, there is a long area of severe stenosis that it's easier to appreciate a little bit on a 3D, okay? And then again, you see the M2, M3 stenosis here, okay? You see that the vessel almost disappears from here to here. So it's pretty tight. And the vessel is about 1.3 distally. So it is a small vessel. But even in this situation, the patient has an NIH stroke scale of 14. It's a quite disabling aphasia, hemiparesis. And we can treat these lesions with careful angioplasty and stenting. And again, maybe this is the better angiogram to show. So you see again M1, M2, and here you have this big M3 branch where it essentially fades away and there is very little in terms of distal flow. So what we did here is we crossed the lesion carefully with a microguide wire. Obviously, when you are this distal, you can't really cross with a J wire, so there is a higher risk of perforation. So you want to be very careful, okay, when you cross. After you cross the lesion, just with the micro wire, you want to do an angiogram to make sure you didn't perforate it before you do anything else, okay? And then only at that point, you're going to take your balloon to the vessel. And obviously you need to use a tiny balloon, 1.5 millimeter by 12 in this case, okay? And you slowly inflate it. These 1.5 millimeter balloons only have one marker, so you slowly inflate it as you did here. So you plastic the segment and then make sure you didn't have a problem. You do this procedure with an exchange length wire. Always, if you are going to do delayed placement of a self-expand stent, you have to do the plastic first and then do the exchange, right? So you need an exchange length guide wire, and then you take your 21 microcatheter in this case, and we can, oops, I had a little second here, the mouse stopped working for some reason. Okay, so after you cross with our, hello?
Yeah, go ahead.
Oh, I think we may have a bit of a problem.
Okay, so just 1 minute. I think Dr. Fischer has to leave as well. So I'd like to really thank him for coming in, taking time out. He's been, as I said, when my thought came about the round table, I called Dr. Fischer to help me out, and he has been kind enough to get in yourself and Dr. Mikael to conduct this successful one. Actually, there were 500 participants, over 500 participants to start off with, and we still have 270 to 80 participants left over. So thank you very, very much. You made it very possible. I think I thank all the attendees as well at this time, because they have stayed on for this long, and hope to have further meetings like this. Dr. Vipul, do you want to say something?
No, thanks a lot, Fischer. I mean, all the discussion with you, they were very lucid, very clear. I mean, I'm purely an interventionist, but it was wonderful to hear all of that. And it was, I think, the way Rajsrinivas said, you helped us organizing this. And already I'm getting messages that, people just want to keep listening. So it's wonderful to have you here. And we hope to have more interaction with you in future for sure.
Yes, thank you for organizing, and especially also a big thanks to Raul and Mikael for taking your time and joining in. I think it was a great discussion. Wish you all the best, and have a good day.
Yeah. Thank you very much. I've met Urs in Mumbai, and and last year in Vietnam also. Thank you very much, Urs, for coming in. Thank you.
Thank you.
Bye-bye.
Thanks a lot, Urs. And we just finalizing the last couple of cases here.
Yes.
So as I was saying, you always want to have that exchange length wire when you're doing this type of self-expanding stent placement post-angioplasty. Okay, I'm gonna talk about an alternative technique, but I still think you wanna have the exchange length wire. Just it's more control in case things don't work. You never lose your access. For balloon-mounted stent, you are using rapid exchange system, so you don't need the exchange length wire. But for self-expanding, it's always a good idea. So again, we did the plastic, right? And then we left the wire there. We exchanged the balloon angioplasty for a 21 microcatheter, and that's what you see here. And here you see an Enterprise stent going up, okay? And this is post-placement of the Enterprise stent. You can see the Enterprise stent here in the M2, M3 area. And you can see that essentially now you have a normal vessel at that segment. You can see here the ends of the stent, and you have remodeled that area completely. Easy to see here in the lateral as well. You can see the markers of the stent, and this may remember this was almost nothing with no distal flow. Now it's almost normalized, and you see that that perfusion deficit that you have initially is now resolved. Okay, you may remember there was a big perfusion area here. So you can even do these procedures relatively distal. I wouldn't suggest you to start doing like a case like this, M2, M3 distal intracranial stenting and plastic. It's obviously dangerous. I only did in this case because the patient was globally aphasic, huge area of hypoperfusion probably wouldn't do well, but it's a possibility, and it's something you should understand. It's in our armamentarium, and you can see here the DWI in this patient. Essentially, it's going to be showing the border zone stroke. She actually did quite well, relatively small stroke burden in relation to what this would have been done otherwise. And again, you can see the chronic lesions. So to finalize, I just want to show two quicker cases, okay? This is how I'm doing self-expanding stent lately. It's not a big experience yet, but it's the non-exchange technique, which I think makes things a lot safer, okay? So this is a patient that came with an NIH not very high, 6, but disabling deficits with a severe aphasia, right? So you don't treat numbers, you treat deficits. And the patient was really aphasic, family wanted treatment. You can see here a significant hypoperfusion. And when you look at the CTA, I want to point out a few things on the CTA. There is tapering of the M1. You see it's a pencil-like lesion. There is a branch type occlusion. Oh, sorry, a truncal type occlusion with the MCA bifurcation spare. And you can see irregularities throughout the PCAs here, okay? So you see that this is likely an ICAT case right off the bat. When you do the angiogram, it becomes even more obvious. You have this M1 occlusion, but if you look at even the distal ACA, you have several areas of irregularity. Look at even at the P-cone, right? You have like a P-cone atherosclerotic stenosis, and even distal ACA, you can see very irregular vessels in a patient that it's African-American diabetic. So this is intracranial atherosclerotic disease. You know that to start with. First thing you do, right? So first thing you suspect. So I load the patient with the medications. Then I'm gonna now debulk the clot and study the lesion. And you can see here that the stent retriever is pinch. It is a better view. You can see it's really pinch here. It could be a hard clot, right? You see in both views here, or it could be ICAD, okay? And in this case, you see it's a very short segment, right? There was no dense MCA vessel, and there was all those findings on CTA and DSA. So it is ICAD, we know that. We also see here that the vessel is very, it's a curvy segment, right? It's a curvy segment with different landing zones probably, okay? So what you did here is you did our pull and bingo. After one pass with the trivo, you can see there is essentially near full reperfusion. And I actually thought I was done. Well, this is pretty good. I'm gonna observe now for 20 minutes. But this patient had a previous stroke, and now, even though you can see the vessel diameters are small, there is a little bit of a mismatch, but there is no way that the M1 is smaller than the ACA. Okay, this just doesn't happen, and it shouldn't be smaller than M2. So I said this is at least 2 millimeters. I can use a 2 millimeter balloon, and here you can really see the area of stenosis. This is just a lenticular striate vessel crossing by, and here you see it's pretty tight, right? So it's a high chance of reocclusion. I felt I should treat this. First thing I did. So here, guys, I'm doing something different. Okay, I'm doing something different. I do have my 5 max DDC here. I cross it with jade wire. And what I'm doing here is I have a coronary angioplasty balloon, just like the other case of self-expanding stent. Okay, it's a 2 millimeter by 12 millimeter balloon. And then I do my plasty. Okay, I did the plasty. But now, as opposed to remove the balloon, put a microcatheter and advance the stent through the microcatheter, okay? To begin with, I didn't use a rapid exchange balloon anymore, as I would typically use. I use an over-the-wire balloon. And the over-the-wire balloon, like a gateway balloon, it's also a microcatheter. So what I did here is I removed the microguide wire. Okay, so here is post angioplasty. You can see improvement, maybe a micro dissection here, maybe not. But then what I did is I removed my micro guide wire, and now I have an over the wire micro balloon, which is also a microcatheter. And then what I did is, through that, I push my neuroform stent, and then I unsheath it, okay? In this way, I don't need to do an exchange, right? So all what you have to do is, as opposed to do the angioplasty with a rapid exchange balloon, you do the angioplasty with an over-the-wire balloon, okay? You make sure you are distal enough of the target area of the stenosis, and then you deploy your self-expanding stent over your over-the-wire balloon, okay? And that's feasible. I don't have great experience with it yet, but obviously you all do that during aneurysm treatment, right? Through a septor. So you can do the same thing with a neuroform atlas as I did here through a angioplasty coronary over the wire balloon, okay? And then here you can see the great result post-angioplasty and stenting with resolution of the lesion. You see the distal end of the stent, and you see the final result with full reperfusion and the MRI with very little stroke burden. It wouldn't be fair if I only show you successes. I have done a lot of intracranial stents. You have a lot of it here in Atlanta because we have a lot of African-American patients and diabetics. But there are problems, and I have lost patients. And the message I want to give it to you is this one. First of all, big ischemic cord. That should have been a red flag there, right? There was a sizable stroke here. Well, I thought, well, 30 cc's is not that big, but look pretty decent size here. Then I had this ICA occlusion. So first thing you suspect, which we did. How I suspect here, guys? Look at this. Look at the PCOM. It's all beat up by atherosclerosis, right? So you know she's diabetic, no dense vessel, and you see a PCA like this, you know this is likely intracranial atherosclerosis. So first thing you do, you suspect. Once you suspect, you treat with dual antiplatelet therapy or glycoprotein inhibitors, and then you debulk. And in this case, it's a solitaire, just to show you can use any stent retriever to debulk. I like the trivial because it shows the whole lesion a little better, but solitaire works just as fine. And after the solitaire pass, I was done, okay? But you see that there is delay in distal flow. So even though we now have an open vessel, the flow is delayed, okay? And then when I look at the lesion, it's just too ugly, right? There is still a lot of plaque burden, micro dissections. It is not a health vessel. And I'm watching this vessel and it's getting worse in front of me, despite the glycoprotein, the thyroid, okay? So I decide to do what I did in the other cases, which is 5 max DDC against the lesion, push the stent, deploy the balloon mounted stent, perfect result, okay? In this case, I said thyroid, but I actually had used not only that, but also heparin. That was early in my experience where I thought stents still require heparin. Stents do not require heparin. They require antiplatelets. They do not require heparin. So what you see here is essentially a final TK3. You see the stent. You know, I do all these procedures, including distal intracranial stenting under MAC anesthesia. Immediately after the procedure, you can see that that cord is always stained. This is not hemorrhage yet. It's stained. The patient got better, normalized, start talking, moving, normal exam. She actually hugged me. The family was very happy. Then about 3 to 4 hours later, she gets worse, loses her exam, and has a fatal hemorrhage. So the truth is, if you do these procedures, you're gonna see this, right? You just need to know how to minimize, and you wanna do these procedures in people who really need it, because yes, she had this bleed, but you know, in someone with an acute stroke scale in the high teens or low 20s, without reperfusion, they either die or have a terrible outcome. So it's like you reserve the more aggressive treatment for the people who really need it. But the message here is you do not need heparin for these procedures. I stop using it altogether. I'm only using tirofiban and or do antiplatelets, mostly ticagrelor and aspirin. And I think my rates of hemorrhage have gone down a lot. I still had a recent hemorrhage despite not using heparin, so it will still happen. And here is the final message for ICAT, okay? It is a common problem, it's challenging, it's associated with worse outcomes. But the stent retriever thrombectomy with tirofiban, it's probably the best approach. A lot of times that will suffice. I really like Raj's case, basal occlusion, did the job, tirofiban, no stent. That is probably what you need to do in most cases. But sometimes you're gonna need to rescue. Avoid heparin. It's best to use ticagrelor and aspirin. You get the effect in 1 to 2 hours. So you may not even need tirofiban, but sometimes you're gonna need tirofiban. Cangrelor is another option. Something I haven't mentioned, but it's critical. Once you open the vessel in these chronic stent occlusive lesions, you have to drop the pressure. And I really drop the pressure to a systolic, typically in the 120s. As long as the map is more than 65, I drop it to 120s, 130s, okay? Otherwise, you have reperfusion hemorrhage. And again, understand the lesion-based selection of the type of stent that you use. I like balloon-mounted if I can. It's cheaper, it's faster, it's easier. But then you can use PTA with self-expanding stent. You learn today the over-the-wire microballoon with no exchange, okay? I almost never use PTA alone in these lesions because they tend to be complex lesions and they, I think, require a stent. And whether or not you did a stent, even after a PTA alone, you're still gonna need aggressive antithrombotic, antiplatelet treatment, okay? So I think that's the main message about ICAD, and I can answer any questions you might have. Thank you.
I think that was absolutely wonderful talks. And we were thoroughly...
Raul G. Nogueira has stopped screen share.
We thoroughly enjoyed, mesmerized, and it has gone on for more than 2.5 hours. We're going to touch almost 3 hours, and still we got around 250 people, you know, there. And many people in APAC have already requested us for posting it online, the video. Because of time difference, many people were not able to attend. So we are going to do that as well. But this was absolutely amazing and wonderful. Raj, you want to
one or two questions as a closing remark. So you said you always use a J, so it doesn't have a problem going through the atherosclerotic lesion if it is a proximal one?
So yeah, so remember, the first thing I do is I cross the occlusion. In all strokes, I use a J. And some people are worried about the J pushing the clot, okay? I believe I probably have done over 1,000 thrombectomies. If that was the case, I would have stopped doing it. And there are videos about this where you can see that the J wire, the wire, it seeks the wall of the vessel. What displaces clot is bigger microcatheters. So always try to use the smallest microcatheter you can to get the job done, okay? And the other thing is, yes, maybe the J will eventually displace a clot, but it's better to have a distal embolus than have a vessel perforation. And you can never perforate a vessel with a J. So I think that's very, very important to use that J whenever possible, okay? Sometimes you have to force it to cross a hard clot, but you can imagine that if you are going with a straight wire and trying to cross, it may decide to cross the blood vessel wall instead.
Yes, yes.
So I still think it's the best thing is to always use the J wire.
And
When you are doing exchanges, let me just finish this. When you're doing exchanges, okay, which you really should try to avoid, and you can use in the second technique I showed, that the wire sometimes moving, right? And that can cause perforations because it's gonna be like very distal. And having that J during that exchange prevents this type of distal perforations, people who are on dual antiplatelets or glycoprotein 2B3 inhibitors.
And that was very nice. You showed different kind of self-expanding stents. In our experience also, we have used Enterprise. Recently, we have used Neuroform Atlas, pretty good results. But thankfully now in India, we have got a dedicated self-expanding intracanal stent Credo by Candice. And again,
Nice.
it can be delivered by a balloon. So these are all very convenient. And of course, but balloon mounted stent remains the cheapest. And when possible, one can just place it with pretty good results. And they're all drug eluting as well. So that was pretty nice. So, and as you mentioned about the antiplatelet protocol, I'm just summarizing for people. You load them with antiplatelet like ticagrelor and aspirin, or you end up giving them loading dose of intravenous antiplatelet agents, right?
Yes, there is no clear difference between intravenous and intraarterial. So in the beginning, I used intraarterial a lot. Now I'm basically using intravenous. I tend to use intraarterial more if I'm doing like an embolization procedure with coils and I start to see coil and clot. Then I typically will do it. But for regular intracranial stent, I just use IV. Obviously, if you have acute stent thrombosis, you're gonna put a microcatheter there and infuse locally. But other than that, I tend to do intravenous. As far as the bolus, there is a lot of debate. Some people do 50%, 2/3. Other people do 80 to 100%. More and more, I tend to do 80 to 100%. But I'm not so sure we know the right answer there. Maybe less is more and it's safer, but I tend to use at least 80% dose. If the stroke is very big or I have IVTP on board, then empirically I may do a little less, 60% or so.
All right, thank you. Raj, you want to ask any more questions or?
We have abciximab available. Is there a preference of GP2B3? You said terifibin. Is there evidence that abciximab has more problems than terifibin? Is that?
So I think, listen, I even though I practice in the United States, as you can guess by my accent, I'm not American. I'm Brazilian. So I understand the reality of developing countries. And I think the first question I have for you is abciximab cheaper than tirofiban in India? If it is, I think you have your answer. You should use it. RioPro or abciximab, it's no longer available in US and I believe in Europe for several different reasons. I don't think there are big differences. I like using tirofiban because 4 hours later, the biological action is essentially out. So what I do, by the way, guys, is if I didn't load the patient with Brilinta and ticagrelor, so I use the tirofiban during the procedure and I start the infusion, IV infusion. Then after the procedure, I'm gonna do a CT. Sometimes it's just a convenient CT in the angio room, okay? And if there isn't big hemorrhagic complication, by the way, staining is fine and it is expected to have staining. There is contrast staining, blood-brain barrier breakdown. You're gonna, right? If there is a stroke, you're gonna have staining. But if there is no hemorrhage, I start my IV infusion and then I load the patient with 180 of ticagrelor and aspirin and I overlap the IV infusion of ticagrelor, of tirofiban with the bolus for 2 hours. And 2 hours after the bolus, I stop the infusion. That's what I typically do. Whether or not it's the best way, I don't know, but it's been working so far.
All right, great. So Raj, should we, also we have got like around more than 40 questions lined up, but I think it's almost 3 hours into this session. So Raj, what do you say?
I think
we will give our regrets to the participants and that that we will not be able to cover these questions. I think everybody's exhausted. What do you feel about it?
Yeah. I think I can. I think so many attendees for 3 hours is a very, very positive sign, and I think I'd like to thank Raul really for making it a very, very succinct the messages that he was delivering, and it was great. I think we may have to close it.
Yeah, I've been talking to Dr. Rajsrinivas that we have to get you to the country. We tried very hard last year for our conference, but it was in our back of my mind that I wanted to have a presentation by you in this part of the world, and thankfully it worked out today.
Yes.
And I just want to be very positive about holding future such sessions with you. I hope you are able to take out time, because it was, as Rajsrinivas mentioned, very, very enriching session, if I say so. Yes.
Well, thank you. It's a pleasure to interact with colleagues from other areas of the world. And I know you are all doing a lot of good work in India. And I hope the COVID-19 crisis goes away soon in our countries and you all stay safe.
That is.
And the thing is, we have people logged in from not only from other parts of Asia, Africa. So it was a little bit of like an international meeting, which worked out. And of course, the COVID situation you mentioned, we don't know. As I told you, just two more weeks of lockdown in our country, and let us see how it goes.
Yeah, I mean, we'd really like to have you over to India after the COVID situation settles, because we tend to conduct these meetings actually on an annual basis or every 2 years, a national meeting. So we'd really, really love to have you.
Yes.
Thank you.
And by that time, maybe a little bit few more online teaching sessions.
Yes, of course.
Yes. So Raj, do we conclude it now?
Yeah, I think
so. We say regrets for the questions. I think all of us are now exhausted, and I thank all the participants. You guys have made it successful, and of course the presenters for them taking out time for such a long session is absolutely exceptional.
Yes.
And for Dr. Rajsrinivas, who actually worked hard to get all the just together and he formed that vision.
Yeah.
Thank you.
In this moment, I'd just like to thank Mr. Jagrup also. I mean, there are people who have been working for us, helping us out in the last few weeks to spread the message across. From Intas is one of the medical companies. He has been really, really helpful, and their team has been very helpful in doing, again, multiple other companies have helped us out, spread the message across, and I'd like to thank all of them for that. And thank Raul for being there. I mean, it's 3 hours. You've done it extremely, extremely well, and it was a very, very captivating session.
Thank you.
I think we can start the meeting now. Thank you. Bye-bye. Have a nice day.
Bye. Everybody stay safe. Bye-bye.
All right. Bye-bye.
Thank you, Mr. Jagrup. Thanks a lot.
Thank you, sir. Thank you. Thanks for giving such a nice platform to us. On the behalf of Mr. N.K. Jain on Intas, I thank you very much to you.
Thank you.
Bye-bye. All the best.
Thanks. Bye-bye.
All the best.
Bye-bye.
Thank you.
Okay, that's you. I'm just exhausted now. I want the question answers, but that can be like another topic.
Yeah, it'll go on for another hour. We can't really.
But engaging 225 people at this time, you are a really magician, sir.
It is. I mean, the speaker was literally. I mean, he was awesome.
Yes.
I think the panel was great.
But sir, Dr. Raul, all speaker, but Dr. Raul is sir. Fabulous was the way he was speaking. Everybody was people. 225 people were sitting here. The way he was speaking.
And I had heard about. I had seen him talking, and I tried very hard for a long while.
Yeah, that's why I brought him there.
So it worked out. So thanks a lot.
Thank you.
Yeah. So just a quick announcement. So we are planning one meeting next week also. So Dr. Vipul. So I had mentioned about the Moyamoya disease. So there's a Japanese speaker which we'll plan next Friday.
I think next week we may also have a carotid disease session.
Okay. So yeah.
I think we can send in a complete schedule about it.
Yes. Yeah. Sure, sir. So yeah,
We have
thank you very much.
and carotid both. It's good.
Yes, yes.
Okay.
Yeah.
Good night, sir. Good night, sir.
Thank you very much. Good night.
Good
And
night.
thank you all attendees. Thank you
Okay.
very, very much. You've made it really a great day. Thank you very much for coming.
Thanks.
Bye-bye.
Uh,
Good night.
Good night.
Good night.